It's on its way, and it couldn't be soon enough, because every moment counts when there's an uncontrolled bleed due to factor Xa inhibitors.
Welcome to the stage, Dr. Sameh El-Fangari.
It happened so suddenly.
Sir, can you hear me? Pressure's dropping. Gotta figure this out fast.
Get him into curtain 4. It's a bleed.
Welcome to the stage, Dr. Sameh El-Fangari.
Good evening, everyone. It gives me great pleasure to welcome you all today for the launch of Andexxa. We're very proud that we are making this product available for patients like Sultan who really have a few minutes with chance of survival, and we all have a role to play here. So I would like to welcome everyone who's coming physically here, and thanks to our partners as well who made this available for many others who were not able to be with us in the room virtually across multiple countries. And I would like to take a step back to give you a background and introduction about AstraZeneca. So AstraZeneca, we are operating in this part of the world and in the UAE for the last 4 decades, 40 years. We are a global science-led and innovation-led company operating in more than 150 countries across the globe. And we are focusing on very specific disease areas that we feel that they are important to take care of. We are targeting the many and the few and the rare. And we are here for the patients suffering from the cardiovascular, renal, metabolic. We are here for respiratory patients and immunology. We are as well helping immunocompromised patients for the right level of protection. We are here for cancer patients as well in different kinds of cancer, so breast cancer, lung cancer, liver cancer, and hematology. And recently as well, we are present into rare diseases, so we are not leaving any patient behind. And in our mission as well, that we understand that how healthcare and environment is overlapping, so we have a commitment towards people, society, and the planet. So we have our sustainability agenda as well that we are championing globally and in the region. So those are the therapy area that we have the focus. There is an overarching mission that we have is to transform patient outcomes across all those diseases. To be very specific in oncology, we are focusing on progression-free survival and redefining cancer care towards survival and eliminating death as a consequence of cancer. And as I mentioned, that we are already global leader in ovarian cancer and in lung cancer, and we are stepping towards leadership in breast cancer, liver cancer, and hematology. And when it comes to the chronic diseases, we understand that our role beyond, of course, providing the best-in-class treatments for those patients, but we help together with the partners to upscale the resilience and healthcare ecosystem to provide the best-in-class care for those patients with an objective of protecting organs and as well as impacting survival and mortality. And for CVRM, where we are, Andexxa fits into this portfolio today, but we have, of course, addressing multiple areas like diabetes, chronic kidney diseases, hyperkalemia, and of course, Andexxa now with the bleeding, and we have as well on anticoagulation. So that's when it comes to the CVRM. For respiratory and immunology, so our focus is asthma and COPD. And we know that it's quite prevalent in this region for us. And we since long time, we are operating and we are providing best-in-class medications for those patients. And recently as well, we have launched our treatment for systemic lupus in the area of immunology. For vaccine and immune therapy, of course, with the COVID, AstraZeneca stepped in to be part of the finding solutions to prevent future pandemics and to be ready for future pandemic. But we are as well have found group of patients that they are not at scale of vaccination, but they are the immunocompromised patients that they needed a protection and they will not get a protection out of the vaccine. So this is where our research is focusing on finding antibodies that can provide immediate immunity for immunocompromised patients in face of any future pandemic. And last but not least, as I mentioned, the rare disease with the global merger of AstraZeneca and Alexion. So we have acquired Alexion portfolio, and we have 5 products currently there and strong pipeline to treat the very, very small number of patients, but they are very critical to the healthcare community. So we believe in pushing the boundaries of science, and and from our R&D to the manufacturing, even to our operation on the day-to-day, we are trying to leverage on data and artificial intelligence to accelerate our pipelines. And you may have observed, because you are coming from different specialties, that in the last few years, we have launched many products, and we are able to accelerate a lot of innovation because of our focus on artificial intelligence and early discovery of innovation, and make sure that those comes to the patient as soon as possible. But we don't stop, of course, on R&D, but we make sure as well that we leverage technology into building scale in our manufacturing and supply chain capability. And that was tested during COVID, and we are continue to challenge our systems, making sure that at a global scale, we are able to respond to change in patient demands and needs across the globe. And of course, we are leveraging digital and artificial intelligence and data, throughout our interaction. The meeting today is an example that for people who were not able to join us, we worked with our partners to make sure that at their convenience, they would be able to make the best out of our gathering today. So when it comes to the patient journey, this is what is actually driving all our strategies all across the patient journey, from early discovery, from understanding the disease itself and what it takes to address those patients, and then working collaboratively with the healthcare ecosystem, either at national level or at an institution level, or even at a clinic level with multidisciplinary team. And we have good experience working for some disease areas, like the one that we talk about today, that would require more than one specialty to be partner into making sure that awareness is there and protocol is there for those patients when they come. Our physicians in the emergency or in the critical care, or if they are neurologists or gastroenterologists or hematologists, or even clinical pharmacists who are making the evaluation of how they would keep this product accessible all the time, because we have 30 minutes to respond, as you can see from patient Sultan video. So this is another example of how we can work with specialties in a collaboration way and bringing a change to the healthcare ecosystem. So landing into Andexxa today, this, looking into the disease, and you have seen this in the video, Sultan is hanging to life for 30 minutes and the clock is like ticking down, and still have a survival opportunity of 50%. However, if the patient was not able to be managed in the right time, there is up to 2.5 folds increase in the morbidity of the patients. So it's not only about the mortality, it's about the morbidity, but the core factor here, or the joining ground for objective for those patients is time. And that's why we are really proud to introduce Andexxa today. It's available in the UAE, very soon will be across all GCC countries. It is the first and only antidote for the factor 10A inhibition that provide 2 minutes efficacy that can help patients like Sultan to survive and hopefully as well reduce the potential implication to the morbidity. So without further ado, I would like to welcome Dr. Sohail Rokn. He is the consultant neurologist in Mediclinic, and he is the stroke unit head in Rashid Hospital, and he is the head of the Neurology Society here in the UAE. So welcome, Dr. Sohail.
Welcome to the stage, Professor Suhail Al-Rukn.
Assalamu alaikum wa rahmatullahi wa barakatuh. Masa al-khair. Good evening. Wow, the room is full. There's no one empty chair there. I'm so proud to be part of this activity today. We are going to have, I believe, an excited time in this meeting. It's the first time that we are getting neurologist, emergency physician, right? Gastroenterology, hematologist to be in one room, which indicates it's a very important topic that we need to discuss today. With no further delay, I would like to thank Dr. Sameh for his introduction. And today, it's a very important day because for us treating physicians, this is a challenge clinical context. And for me, as a stroke expert, welcome to Rashid Hospital. We will see many of these patients coming with the bleed, and Sultan is one of them. Dealing with ICH patients like Sultan suffering a hemorrhage while on anticoagulation is a real clinical dilemma. The mortality and morbidity risk is high, as you have seen earlier on the screen. 50 to 60% of the patients, they will die in the next 3 days. That's why it is very important for all of us who are part of this patient's journey, emergency physician, hematologist, ICU, neurologist, gastroenterologist, and all physicians. Everyone is responsible for saving these patients' lives, to be aware of the bleeding risk and optimal way of management, and that's why we are here today. Today's program is rich and comprehensive, and our first segment is titled, guess, Time is Brain. Time is brain. That is the message that my student, my resident, they are getting because of ischemic stroke. Now we are going to a new field, which is the ICH, where we will cover the background on the bleeding risk among anticoagulated patients, their expected outcome, and the new treatment. With Andexxa alpha, with the potential to save their life and their quality of outcome in the future. I would like to thank AstraZeneca to gather us today here to update ourselves and our medical community regarding the new innovation in the field of medicine. With no further delay, I will start with my colleague and dear friends, Professor Mahmoud Al-Marashi. Professor Mahmoud Al-Marashi is a well-known figure in the field of hematology, thrombosis. If Suhail have any issue anywhere in the private sector, Mahmoud is always available there to ask him. At the same time, Professor Mahmoud is the Vice President of Emirates Society of Hematology. He's a senior consultant hematologist at Dubai Health Authority and Mediclinic City Hospital in Dubai. His talk will be followed by my colleagues, Professor Stephen Meyer. He will join us virtually from the US. Professor Meyer is the Director of Neurocritical Care and Emergency Neurology Service at Westchester Medical Center with the health system and Professor of Neurology and Neurosurgery at New York Medical College. Professor Stephen will be sharing with us the science behind Andexxa alpha, the evidence supporting this innovation molecules, and his experience with this medicine. With no further delay, Professor Mahmoud.
Welcome to the stage, Professor Mahmoud Marashi.
By the way, this was very high. Do you want me to keep it down?
Thank you very much, Suhail, and also showing my height as well. Thank you very much. At least you didn't mention about my age, you know. Okay. Thank you very much, and really it is a pleasure to be here today to share with you the issues of important issue actually of how to control bleeding in situations where it is so critical to control this very, very urgently. And so he'll say time is brain actually. The faster you correct this, the better it is. So what do you think of when we think of anticoagulation? What comes to our mind? Of course, what comes to our mind is the various situations where we need antithrombotic therapy, arterial and venous thrombosis, cancer-related thrombosis, surgical prophylaxis after surgery, acute illness prophylaxis. So we need an anticoagulation either at the therapeutic dose or on prophylaxis for all this condition. But when we do this, we're always cognizant of the complication, and the most important complication, of course, is bleeding. So this is something we always think about and how to manage this one, how to try to reduce the risk. So we had been having the oral anticoagulants. Warfarin has been there for many, many years. And it's a good anticoagulant, but unfortunately we know there's so many complications related to warfarin. And we all have, sometimes it's like a bad relationship. You don't know. INR is okay and nothing happened. Suddenly INR goes up, suddenly INR goes down, trying to find what happened, what's wrong, why is it behaving like this? And you don't find. Sometimes, of course, there is a reason, but many times we don't find a reason. So we need something that at least is more dependable. And luckily now in the last 12 years, we have had the direct oral anticoagulants, of which the factor 10A inhibitors are the most important. And apixaban and rivaroxaban are the leads in this one. They act directly. They don't go, unlike warfarin, indirect. This is a direct inhibition of the active factor 10. So 10A, it acts directly to inhibit 10A, therefore it inhibits thrombin formation and clot formation. So this is how it works. So it's very easy and it is dependable, and you don't have to worry of checking INR and worrying about this one. So warfarin, we have seen warfarin is indirect anticoagulant. It works by interfering with the vitamin K-dependent coagulation factors. It interferes with the carboxylation of these factors, which make them active. So these factors become defective. They don't work properly, and that's how it produces its effect. And we know how to measure it. We keep an INR. We have to keep it at a particular level. And then when the patient bleeds, what do we do? So we have deficiency of these 4 coagulation factors. So we have the 4-factor PCC, which we use to try to correct. And it works well, actually. If you give this in patients who have got high INR, it does lower the INR. But unfortunately, it may not lower INR to the level that you want. Suppose you want to have emergency surgery to remove a bleed in the brain. This really doesn't control it as well as that to allow you to do immediate surgery. If you overcorrect, of course, there's a problem of thrombosis, which is very critical for the prothrombin complex. Thrombosis is something very, very problematic. So if you are using a 10A inhibitor like Sultan had been using, what can we do? How can we correct this one? Should we use that? This is something that has been, before Andexxa was available, it was recommended to use a 4-factor PCC. But does it really have any effect? And you can see really it has got 0 effect on the anti-10A level. And you can see the saline and PCC actually equivalent. So really it doesn't have any effect. So you cannot really depend upon this. And you can see that we are seeing more of these patients like Sultan. Why do we see more of this patient? You can see in the prescription of these anticoagulation, you can see warfarin is gradually coming down, while these apixaban and rivaroxaban really being the use increasing tremendously. And this is actually ending at 2017. Now 2023, you can see warfarin is much lower, and these direct anticoagulants are much higher usage. And if you can see, therefore, patients coming to emergency visit for bleeding, in the past, Warfarin was the commonest, and it was really most of the emergency visit, the most common cause was warfarin-related, patient who needed admission was warfarin-related bleeding. That's becoming less, and we are seeing more patients coming with bleeding secondary to 10A inhibitors. The 10A inhibitors, their bleeding risk is much lower than warfarin, but it does occur, especially patients who use. Many of these patients are elderly, they tend to fall, and they can have traumatic bleed and other things. So it's really a big problem. And you can see the overall major risk of major bleeding is about 3.3%. Now we have our gastro colleagues here, Dr. Samir, Dr. Mazen. They can manage the gastrointestinal in most cases, so the patient will be able to go home after that. But still, sometimes you need something to correct this bleeding quickly. So even they want to do endoscopy, they want correction. So they can. But unfortunately, if you have critical site bleeding, or most importantly, intracranial hemorrhage, which Suhail has to deal with, really the prognosis is completely different. And you can see both with rivaroxaban and apixaban, almost nearly 50% risk of mortality within 30 days. So it is something very, very serious. And you can see 48% risk of death. And those 52% who don't die, unfortunately, many of them, 65%, they have moderate or severe disability. So really, you need something. As I say, time is brain, and you need to correct this. Just like in thrombosis, you need to clear the obstruction within a few minutes, 30 minutes or less. The same thing with hemorrhage. You need to stop the hemorrhage fast. You need to be able to allow the surgeon to be able to do the surgery immediately if it is required. And that is something that's very important. And how can we change the fate of these patients? So I will let Suhail introduce the next, go to the next, and we will hear how to do this. So it's very, very important. Thank you very much.
Thank you, Professor Mahmoud. It's very clear that Professor Mahmoud went different intrinsic, extrinsic pathways. Then he spoke about the mortality and the need of having something to treat these patients who's anticoagulated and they bled at the same time. So with our next speaker, is he with us from the US? Is he online? He's online? Excellent. Professor Stephen Myers, welcome, my friend.
Welcome to the stage, Professor Stefan Meyer.
Hi, Stefan.
Hi, you can hear me?
Yes, we can hear you. The room is full.
Okay. It's a wonderful honor to be here as part of this program. I'm coming at you from New York City, where I live and work. I'm a neurointensivist, and I've been taking care of intracerebral hemorrhage patients for my entire career. And it's very special when there are new developments and new treatments that we can incorporate into our clinical practice. So obviously, we're going to be talking today about Andexxa alpha, known as Andexxa. Andexxa is the only approved antidote for life-threatening or uncontrolled bleeds in patients taking the factor 10A inhibitors, specifically in the US, apixaban and rivaroxaban. And this slide here shows on the left the various forms of anticoagulation that we might encounter, right? The 10A inhibitors, the vitamin K antagonist, warfarin, and dabigatran, which is a direct thrombin inhibitor, and showing the different types of interventions that we have that are specific for reversal. We have Andexxa here, which is the focus of our talk. We can use the 4-factor PCCs and vitamin K replacement for warfarin, and we have idarucizumab, which is a specific antibody that binds and sequesters dabigatran. So what is Andexxa? Andexxa is a recombinant protein. It's a copy of factor 10A, but it differs in that it lacks the specific region that catalyzes thrombosis. So when you flood the circulation with this decoy molecule that looks like factor 10A, it actually will sequester the factor Xa inhibitors, and that in turn allows the patient's native factor Xa to be able to catalyze thrombosis, as shown here. So it's a decoy molecule that sequesters the anticoagulant medication to allow the real factor Xa to do its thing. What is the science behind the clinical development of Andexxa? Well, it starts with two studies known as Andexxa A and Andexxa R. Why are they called A and R? Well, one of them looked at the factor A, and the other one looked at rivaroxaban and apixaban. So these were two phase 3 studies that were conducted to confirm the efficacy and safety of these agents in anticoagulated healthy volunteers that were given factor Xa inhibitors. The percent change in these studies of the primary endpoint was change in anti-10A activity. And you see the data here. So whether it's apixaban or rivaroxaban, you see that within minutes, there was an over 90% reduction in anti-factor Xa activity. And you see that in these studies, it lasted for 2 hours. And that's because the medication is given as an IV push bolus and then a 2-hour infusion. So you can see the efficacy here, and at the end of the infusion, you see a little bit of rebound of the anti-10A activity. At the same time, in Andexxa A and Andexxa R, they also recorded increases in thrombin generation, right? So you see this immediate increase in thrombin generation during the bolus and infusion period in both of these studies. In these studies, there were no thromboembolic events, and there were no serious or severe adverse events recorded. That brings us to the next study, Andexxa 4. Andexxa 4 was a multinational, prospective, single-arm, open-label study in actual patients with critical bleeds, CNS bleeds and GI bleeds mostly. In this study, they were given Andexxa, and if they were given a 10A inhibitor within 18 hours of presenting with their medical emergency bleed. There were two co-primary endpoints: percent change in anti-10A activity and the rate of excellent or good hemostatic efficacy recorded 12 hours after the infusion. So in addition to anti-10A activity and overall safety, hemostatic efficacy and mortality were also studied in Andexxa 4. Again, the primary efficacy objectives you see here on the left, and the safety objectives here, including a close look at thromboembolic events and 30-day all-cause mortality. In Andexxa 4, there was a 93% decrease in anti-10A activity in patients that were receiving apixaban or rivaroxaban. And you see the number of patients here, 347. And there was a 79% rate of hemostatic efficacy among all patients. There were different ways of defining hemostatic efficacy depending if it was a systemic bleed, a GI bleed, a CNS bleed. But overall, wonderful results. The overall mortality rate in Andexxa 4 was 16%. And you see here broken down 70% mortality in intracranial hemorrhages, 13% with GI bleeds, and 15% in patients with other types of bleeds at 30 days. The thromboembolic event rate in Andexxa 4 was 10.4%, and there was 0% or no patients had any type of thromboembolic events after resumption of oral anticoagulation. And that brings us to Andexxa I. Andexxa I, folks, is hot off the presses. It was just, the data was first announced a few weeks ago in Toronto at the World Stroke Conference. The definitive paper has not yet been published, but I'm going to give you a sneak preview of what this data showed. And why was Andexxa I performed? because this was a study that was restricted to intracranial hemorrhage patients, and it was randomized, open label, blinded endpoint that was comparing administration of Andexxa alpha to usual care. Now, in this trial, usual care, 87% of the time, amounted to administration of a 4-factor PCC, or prothrombin complex concentrate. So this was the first study of its kind to directly compare this agent, Andexxa, to 4-factor PCCs, using a very detailed analysis of intracranial hemorrhage volumes on follow-up CAT scans. So this study further refined the definition of hemostatic efficacy, and I would like to walk you through it. Hemostatic efficacy was defined in Andexxa as a less than 35% increase in hematoma volume on the follow-up scan at about 12 hours. So if, say for instance, you came in with a 10 milliliter hemorrhage and on follow-up it doubled to 20 milliliters, that's not effective. And that patient would not have hit the primary endpoint. So you had to have a fairly stable hemorrhage volume, but there were more criteria that you needed to meet. You also had to have a fairly stable neurologic examination, defined in this trial as a 6-point or less increase in the NIH, National Institutes of Health stroke scale, from baseline to 12 hours. You had to have a fairly stable hemorrhage volume, fairly stable exam, a little bit of wiggle room for increases in both. And in addition, to meet the primary efficacy endpoint in Andexxa, you could not have received any rescue therapy, no repeat doses, let's say, of Andexxa alpha, no rescue therapy with recombinant factor 7A, or any other kind of procoagulant treatment. So, Andexxa was stopped early at a midpoint interim analysis because there was already statistically significant evidence that the pre-specified endpoint had been met, showing superiority of hemostatic efficacy for patients receiving Andexxa alpha compared to usual care. Here's the graphic showing the primary endpoint. 64% of patients in the active treatment arm that received Andexxa had good or excellent hemostatic efficacy at 12 hours compared to 52% with usual care. This was a relative increase in good or excellent hemostatic efficacy of 21%, and you see here statistically significant at the level of p = 0.008. There was also a much more significant reduction in anti-10A activity, as we saw in the prior studies, as a secondary endpoint, as you see here, measured at both 1 hour and 2 hours. Overall, 2 hours, a 94% reduction in anti-10A activity. Mortality was balanced between both treatment arms at about 28%, as you see here. The thrombotic event rate was in line with the known safety profile of Andexxa from Andexxa 4 at about 10%, compared to 6% with usual care. And please note, this study was not designed or powered to show differences in mortality or thrombotic events, but they were recorded, of course, and they are important, and this is the data. So, Andexxa has demonstrated also mortality reductions in real-world use. There are 3 studies showing this. I'm going to walk you through these. The first was a real-world study of a retrospective survey of electronic medical records in patients on 10A inhibitors presenting with critical life-threatening bleeds. And I want to draw your attention to the intracranial hemorrhage comparison here. You see 9% mortality in patients that received Andexxa alpha compared to the pink bars receiving in order FFP, fresh frozen plasma, 4-factor PCC, or any other type of hemostatic therapy. And you see very similar trends in all the other diagnostic groups, including trauma and GI bleeds. The next study found a 50% reduction in mortality in patients that were given Andexxa alpha compared to 4-factor PCCs. This was also a hospital-based study of over 4,000 patients presenting with critical bleeding. And you see here the data in the intracranial hemorrhage patients, 45% reduction in mortality recorded here. And then finally, there was a third study, international and post-hoc analysis, again comparing Andexxa alpha directly to 4-factor PCCs in patients on 10A inhibitors with life-threatening major bleeds. And you see the mortality for the intracranial hemorrhage patients was 15% compared to patients treated with PCCs where the mortality was 49%. And you see here the relative risk reductions of mortality in the entire cohort, the intracranial hemorrhage cohort, and the GI bleed subgroup. So a growing body of peer-reviewed evidence is occurring which supports the use of Andexxa alpha as the agent of choice for reversing anticoagulation in patients on 10A inhibitors with life-threatening bleeds. And there's no form of bleeding that's more life-threatening than intracranial hemorrhage. So what I'd like to add next is mention that in multiple guidelines, it's a busy slide, but to summarize basically what all of these guidelines emphasize is that at your hospital and your institution, when you have a patient like Sultan presenting with something that's literally threatening their life, you want to administer the best available antidote to reverse the anticoagulation that is available to you. So if you have Andexxa alpha, that would be the agent of choice, obviously, for the 10A inhibitors. But I think it goes beyond that. In terms of using the best agent available, what about the factor of timing of anticoagulation? So I'm going to talk about that next. Again, just emphasizing the clinical trial, Andexxa, the real-world validation. In the United States, and actually internationally, there is a move afoot for a treatment platform that we call Code ICH. There's a white paper that's currently under review that hopefully will be accepted and published soon. 18 experts in intracranial hemorrhage treatment from around the world reviewed the literature and basically came to the conclusion that it's time to get serious about time-based quality and performance metrics for intracerebral hemorrhage. So to illustrate the point, many stroke centers have been focusing for a very long time on various quality metrics for the treatment of acute ischemic stroke. This is one example here of a New York State hospital, and you see here 15 different stroke-specific performance metrics for acute ischemic stroke. At the same time in this hospital, there are only 3 performance metrics for the treatment of intracerebral hemorrhage, which is interesting because, as we all know, the mortality rate and morbidity rate for intracerebral hemorrhage is vastly higher when you bleed into your brain than when you infarct your brain. So this expert panel has proposed that we now institute in our stroke centers a 60-minute door-to-needle target for the emergency reversal of blood pressure when it's highly elevated, and a 60-minute door-to-needle target for reversal of anticoagulation if you're bleeding in your brain and you're on any form of anticoagulation. Code ICH is an aligned pathway for the treatment of hemorrhagic stroke that meant to fill unmet needs because there's a lot of variability and inconsistency around the world in how we approach the emergency management of acute intracerebral and intracranial hemorrhage. This is a grassroots initiative arising from the people on the ground, boots on the ground, that actually take care of these patients. So it's basically a call to arms and a call to action that we need to do a better job and be serious about how we treat this life-threatening condition. And it's our hope that Code ICH will endure as a platform for years to come as we continue to implement the very best evidence-based practices that we have for treating this life-threatening emergency disease. Time is brain. And I would like to thank you for your attention and hand it over to the moderator.
Thank you, Professor Stefan. Before I forget, I would like to ask all the audience and those people on the virtual meeting that there will be a barcode next to you on the table. If you have any questions, please screen it and put your questions so we can read it from the iPad. And if you have a burning questions that you would like to stand and to speak about it, also we are open for that one. And for the people in the virtual, please will be available also for your questions. Just before we are going to the next session, Professor Stefan, thanks for a nice presentation. The prof went through many data there, speaking about Andexxa A trial, R trial, and then he went to the only clinical trials, which is a randomized open one, the Andexxa I, and he spoke about that 35% of the patients, their ICH volume or size decreased compared to the standard care. And the NIH stroke scale, which is very important in the field of stroke and neurology, has dropped by 6 compared to the control arm. And from the real data, world data, that's mortality also has been decreased in the trial which has been, or the registry for the Andexxa. Then at the end, he came with a new concept, which is very interesting, which is the ICH code compared to the stroke code and door to needle. So thanks, Professor, for that, and we will keep the Q&A till the end. We will move forward, and with this, we have conclude the first segment of this event, which is Time is Brain, and I would like to please ask Professor Zuhair Al-Asiri to come to the stage from Saudi Arabia. Professor Zuhair is a senior consultant at Department of Clinical Care and Emergency Medicine at King Saud University and Medical City. At the same time, he's at Dar al-Ulum University. He's the leader of adult ICU in the MOH and the founder and the director of Telecritical Care MOH 2021. So in Saudi Arabia, they are doing telecritical care, tabarakallah, and that's something maybe we can share later about. It's something new for me. And he's the first chairman and founder of the Department of Emergency Medicine, King Saud University. Welcome, Professor Asiri.
Welcome to the stage, Professor Zuhair Al-Asiri.
السلام عليكم وأسعد الله مساكم جميعا بكل خير. Thank you very, very much, Dr. Suhail, for your nice introduction. I'm very thrilled and excited when I see a lot of specialists and sub-specialists meeting together to come up with the protocol and guidelines, and maybe talk about something very serious to deal with, which is a patient who come to the emergency departments with bleeding, either with the life-threatening bleeding or bleeding in the critical care areas, or patient might need massive blood transfusion. If this presentation to be done like 20 years ago, most of the decision maker will be only a hematologist, maybe a stroke physician, cardiologist, but nowadays everybody on board. And that's what we learned from most of the accreditations body. If you really want to have a success story about managing critically ill patients in anywhere in the hospital, you have to have a multidisciplinary team to approach to the problem. And here we are. We are today talking about medication that we want to elaborate more about its indications in some type of patients. But it's not only anymore a one-man show. It's a multidisciplinary approach where emergentologist, intensivist, cardiologist, stroke physician, hematologist, gastroenterologist, internist, pharmacologist on board to come up with the guidelines and the protocol about using Andexxa and patient to come to the hospital with a DUAC-related bleeding. I'm very happy to be part of the team today. I'm very thrilled, to share this session where we link the previous presentations and presenters about the science of Andexxa to link it to the real cases that my colleague dealt with in their hospitals. And without further ado, I would like to introduce them. First presenter will be Professor Andexxa Zahrani, whom I know very, very, very well from a long time ago when I was a medical student. He's the Deputy Director of Cancer Center of Excellence in King Faisal Specialist Hospital. He's an adjunct professor of internal medicine and hematology at Al Faisal University. He is acting chairman of hematology, stem cell and transplantations and cellular therapy department. He's participating and running and chairing a lot of clinical trials related to thrombosis and hemostasis, and he will share with us some of his experience in dealing with the DWAC-related bleeding in King Faisal Specialist Hospital. Our second speaker will be Dr. Samir Al-Awadi. He's a consultant gastroenterologist, head of digestive disease unit at Al Rashid Hospital, and he's the president of Emirates Gastroenterology and Hematology Societies. He will enlighten us about some of the GI cases and maybe moderating some discussions about GI-related bleed in DWAC patients. And last but not least, Professor Jay, he's an emergentologist, chairman of and consultant in adult and pediatric emergency medicine at WAM Hospital. He's adjunct assistant professor as well, and he's have a lot of experience in writing chapters and books and related to emergency medicine, specifically the one that been released in Oxford Handbook. And he's an expert in medical legal cases. There we are, and negligence committee. Just to put this in the context, I've been doing emergency and ICU in the last 25 years. So when it comes to outcome of any medication, do not only have tunnel vision about the specific minor outcome when you look at patient level. Sometime you have to change the way that you look at the outcome to look at the population-based outcome. And when I speak about this, when you want to look at the mortality, do not look at the mortality alone. Look at the SMR, the standardized mortality ratio, where you look at the PASH score and link it to mortality rate as well. When you want to talk about medication that could save life, you have to look at would this save me ICU bed or no? Would this save me another ICU day or no? And when you put this in mind and put this in context, then you could have the right decision about using any type of reversal agent in medicine. Without further ado, I would like to welcome the speaker to come to the stage, and Professor Andexxa will be with us virtually. Prof. Andexxa, stage yours.
Welcome to the stage, Professor Andexxa Al-Zahrani. Welcome to the stage, Dr. Samir Al-Awadi. Welcome to the stage, Professor T.T. Jaganesh.
Oh, sorry. Can I start, Professor Asiri?
Yes, you can go ahead now, please.
طيب بسم الله والحمد لله والصلاة والسلام على رسول الله. Colleagues, assalamu alaikum. It's a great honor and pleasure, and I really again apologize for not being with you physically. And I'll start my presentation and share with you two cases that we have treated at our center with Andexxa. We have introduced Andexxa to our hospital more than 2 years ago, and it was restricted initially, and at the beginning of this year we are using it more often, and we have treated so far 8 patients since January with Andexxa. As Professor Stephen Meyer has already introduced elegantly. He listed the scientific organizations that endorse the use of reversal agents, and some are particularly mentioning andexanet alpha as a reasonable option to reverse anticoagulation effect in patients receiving factor 10 inhibitor who develop or present with intracranial hemorrhage. This was the American Society of Hematology, Heart Association, and American Stroke Association. This was also the same recommendation by the European Stroke Organization, that they stated that andexanet alpha should be administered, preferably in apixaban or rivaroxaban-related intracranial hemorrhage. So this is the first case that I wanted to share with you. This was a 77-year-old lady who was known with multiple ischemic cardiac disorder related manifestations. She also had aortic valve problems and underwent TAVI, transaortic valve implantation, in 2016. She was diabetic, and she had hemarthroplasty 2 years before her presentation. She had uncontrolled hypertension and was also known with atrial fibrillation, with high CHA2DS2-VASc score and also lower Has-Bled score. So she was treated with apixaban 2.5 milligram twice daily. And when she came to our emergency room, she was already 15 hours from the time she had her last dose. She presented to the emergency with left arm numbness and dizziness and confusion. Standard supportive care was performed, routine laboratory investigations were done, and immediate brain CT scan was taken. Her CBC showed no drop in her hemoglobin, renal function was normal, her INR is 1.2, and her white cells were within normal limits. The brain CT scan showed right thalamic focal hyperdensity, which was read by the radiologist as intraparenchymal hemorrhage with surrounding perilesional edema. As expected, of course, anticoagulation was continued, mechanical thrombophlebitis was initiated. The surgeons, neurosurgeon stated that this will be managed conservatively with no surgical intervention. Immediate reversal with andexanet was done using low-dose andexanet because her apixaban dose was less than 5 milligram and her last dose was more than 8 hours from her presentation. This is her CT scan showing the thalamic bleed and another CT and another cut. This was an incidental old finding of parasagittal calcified meningioma that was there for at least 2 years. And you can see the right thalamic focal hyperdensity suggesting the intraparenchymal hemorrhage. This is a follow-up CT showing a significant change, a reduction in the hematoma size. And here is our power plan order in the integrated clinical information system, which we made before introducing the drug, where you order the andexanet, then you get two options, either a high dose or low dose, and this guides you on when to use the low dose or high dose. And we, in the guidelines, we also, this is restricted to hematologists, the guidelines suggest some laboratory investigations like the drug level, but also states and stress on the fact that you don't need to wait for the anti-10A level. And whenever indicated, you immediately start the andexanet. So this patient received andexanet alpha, 400 milligram intravenously over 15 minutes. And then she received immediately 2 minutes later, the second dose, which was 480 milligram IV over 120 minutes. You saw her brain CT scan showing the bleed, and then she underwent serial imaging to evaluate the response of the interventions stated. She had no thrombotic events on her 10 days of in-hospital stay, and there was no increase in the size of the hematoma, which is a very positive sign, as stated by Prof. Steve Meyer, where in the last study that he presented, no increase in the size of the hematoma of less than 35% is a positive sign. This patient had actually no increase at all in her hematoma size over the imaging studies that was performed after her presentation. So her outcome is that the thalamic bleed remained stable, and this was a positive sign. The fact that she had been discharged within 10 days after the bleed with rehabilitation, physical therapy, and occupational therapy in order to regain her strength. She was followed up 2 months later and was doing very well. And 1 month after her presentation to the emergency, she was restarted with 2.5 milligram of apixaban, and her blood pressure was much more controlled at the time of her presentation. When she came uncontrolled blood pressure, the apixaban and the old age were contributing to her bleeding. This is the second case, which was who was a 51-year-old lady. She was a widow, para 6, normal spontaneous vaginal deliveries. She was referred to our hospital from another referral center with the herpes human papilloma virus associated cervical cancer, squamous cell type. She was known with uterine fibroid and had a PET scan at our hospital to evaluate the cervical cancer, and unfortunately it showed advanced disease with locoregional metastasis and also lung metastasis. She had a cancer-associated thrombosis in the local hospital and was treated with apixaban 5 milligram twice daily. A few months later, she came to our hospital and presented with severe vaginal bleeding that was associated with hypotension, tachycardia, and basically a hemorrhagic shock. She had no history of headache or decreased level of consciousness, or dizziness, or visual changes to indicate possible CNS bleeding. Last dose of apixaban was less than 8 hours from her presentation. She had a significant drop in her hemoglobin and was treated with usual supportive care, fluids, and uncross-matched blood was given. The gynecologist was consulted. The colleagues from radiation therapy were also consulted for considering hemostatic radiation therapy. And she was treated with Andexxa to reverse the apixaban therapy. So this was the regimen that we have used. As expected, you will need the high dose. So she received 800 milligram bolus followed by 8 milligram per minute infusion. She also received vitamin K immediately. This is her hemoglobin drop from a baseline of 10 to 6.2. And she had some coagulopathy. That's why we elected to give her some vitamin K. And this is again the power plan order for the Andexxa alpha, the same format, except that the dose here is 800 milligram and the initial immediate bolus. This is given over 30 minutes instead of 15 minutes. And the subsequent infusion of 960 milligram over 120 minutes. An IV inferior vena cava filter was inserted. There was no signs of bleeding after the start of the supportive measures, and she remained clinically stable and had no complaints. She was discharged again 10 days after the active bleeding and was treated with chemoimmunotherapy. Last dose was the subsequent dose after the immediate bleed was around 1 month after the presentation. So I think these are the two cases that I wanted to share, and I'll be happy to discuss any questions at the end of this session. Thank you, Professor, and thank you, colleagues, for the listen.
Well, thank you very, very much. That's very nice cases, and I'm glad they have very good outcome, and you have you followed up, in your patients, and they are still having very good function of life. That's very good. I have two questions. Who usually order the Andexxa in your institute? Is emergency physicians has the right to order the medications upon the patient arrival? Yeah. Or there is specific protocol and guidelines in ordering the Andexxa?
Thank you. The Andexxa alpha is restricted to hematologists, but we have a 24-hour service. So the hematologist will reply to the emergency request, and we approve it. Then they are the ones who order it. Of course, the clinical side of hematology evaluation is performed immediately by fellows, assistant consultants, and when needed, consultant hematologists. So the short answer is we get the approval, and it is immediately approved whenever it's indicated, and the colleagues in ER order it, and it's administered by nursing.
Is the care protocolized, or still it's by the hematology decision to decide about using Andexxa?
No, we guide using the power plan. And, I think this power plan makes it very easy for the emergency room colleagues to have a very crystal clear, order and implementation of the reversal agent. So it's a matter of just, because sometimes we got consulted about epistaxis, about some minor bleeds, and we thought to restrict it to, because of two things, cost and also potential, side effects or any other unwanted, problems related to the overuse of the drug. We had a similar problem with the factor 7, where it was initially introduced for hemophiliacs with inhibitor, and then 90% of the utilization a few years later was for an unapproved indication. So, and actually, I can tell you that we had 2 unapproved usage for reversal pre-operatively in a cardiac transplant patient and another organ transplant patient.
Sure. Maybe there'll be a time where Andexxa could be protocolized and in the hands of emergency and frontliner as well. My second question is kind of practical question. Your second case, she has 4-gram drop in hemoglobin, but she received only 2 packed RBCs. Is this kind of standard of care? Or
No. She received more, but I have not digged into the details. I wanted to focus on immediate emergency room intervention. So. She required more, of course. Yeah, thank you.
Thank you very much. That's very good. Great.
Thank you.
So maybe Dr. Samir, if you could elaborate more on the other type of complications of DUAC-related bleeding, and when it comes to the GI bleed, as they are maybe the most common cause of hospitalizations of DUAC patients.
Yeah, as you mentioned, and as was illustrated earlier with Dr. Mahmoud Marashi, that the rate of DUAC use has increased in the past years. Moreover, all of these patients are with comorbidities, age of 60, 70, 80, and more. And these patients are very critical, and they either present with GI bleeding or intracerebral hemorrhage, as mentioned earlier. And I think we can see from Dr. Jay's cases, he will present some nice cases of all patients that they kind of avoided endoscopy and manage with the Andexxa. So it's a major issue, and usually we want to stabilize the patient before doing the endoscopy. So I think it will be a good component to our critical care patients. So, Dr. Jay.
Thank you.
Assalamu alaikum. Good evening, ladies and gentlemen. At the outset, I would like to thank AstraZeneca, and in particular Mr. Hamdi, Ms. Abir, Mr. Mahmoud, and Ms. Nadine for actually kindly inviting me on this stage to give a talk on this August eminent presentation that's going to happen here for today on Andexxa alpha. I would also like to pick up Professor Zohair's message that these kind of patients are actually managed as a multidisciplinary team, not as just as one physician or ER can't take the claim. So I would like to thank my august audience who are come from Tawam, Dr. Hind from our emergency department, adult division chief. I have Dr. Hala, who's the ICU chief, Dr. Amr, who's the hematology consultant, and I have Dr. Omar from anesthesia because some of the cases have gone to OR, and my gastroenterology team. I have quite a few of them here, Dr. Masin, Dr. Fatma, and Dr. Eva in the team. So without them, I don't think we would have had any successful cases that's happened. So thank you very much for being here and for your help and input into the cases that we are going to present. Turning point is an important thing. As an emergency physician, we are adrenal junkies, we are resuscitationologists, and time is of the essence. But when somebody is bleeding heavily, you have a couple of options. We would say in trauma, we would take them to IR, or we can take them to OR. But somebody who's on a DOAC, who's on an anticoagulant, nobody in the OR or anybody in the IR is going to take them unless we start to turn the tap. Not alone in surgery, which is a part of closing the tap. For these patients, using a reversal, appropriate reversal agent is key as closing the tap. If you don't close this tap, the subsequent measures of IR or OR is not going to happen, and that is why it is actually quite important of using the appropriate reversal agents in these cases. So the talk is divided into 3 aspects. What we will do is we will look at 5 cases. My dad always says, son, you're like a goldfish. And I never understood what a goldfish meant and why he kept calling me a goldfish. Apparently, a goldfish's attention span is about 9 seconds. Technically, my attention span is only 8 seconds. He says I'm actually worse than a goldfish in attention span. So all my cases and highlights are going to be very simple, direct, and to the point. So we will have 5 cases, 3 of which is going to be on gastroenterological bleeding, which is the majority of the cases that we see from DOAC-related complications. A couple of them on intracranial hemorrhage. And then we will talk about the dosage and regime of Andexxa alpha. And finally, Professor Zohair was saying, asking my colleague, Professor Hassa, have you pulled up any kind of guidance or guideline? And we are trying to work in Tawam some kind of a guidance. Looks like I'm already having some effect and impact in the audience. So without much ado, let's go into the first case. It's a 75-year-old female from a long-term care facility, has multiple comorbidities as they normally do, hypertensive, diabetic, liver cirrhosis, and she had a new onset of AF for which she was started on apixaban 5 milligrams BID. She comes into the ER with a lower gastrointestinal bleeding at about 8:15 a.m. We said, okay, we'll stop the apixaban, and we gave tranexamic acid. I know my gastroenterology colleagues will not be very happy with me because of the halted trial that came out and tranexamic acid not having a good amount of impact and no benefit in their mortality. However, I will ask them to go and read the systematic review in 2023 that's been published, which may change their mindset. Anyway, we gave them tranexamic acid, and this is the point to say we are not trying to hide anything. All these cases happened as it is, and that's what's being presented. We admitted this patient to internal medicine, and gastroenterology team told us, you know what, get the patient in, put them into a CT angio, and then we will do the scopy. And usually gastroenterology scopy's advice is usually 24 hours later, unless they are in a variceal bleeding. They take their time. They don't understand we have a 3-hour target and we need to keep moving. But we did a CT angio at 2300 hours, and there was a small amount of rectal luminal contrast extravasation as it's shown in the CT pictures. And they decided, you know what, Jay, get some more blood, give some more TXA, give some FFP, and we will sort the patient out tomorrow morning. It's close to midnight now. Let's see it in the morning. And then lo and behold, what happens is 8 o'clock in the morning, the patient has a massive hematochezia, which is a lower GI bleed. Critical care gets called in, and then they said, you know what, this is a massive bleed. Patient is hemodynamically unstable. Let's try and reverse it. And well, we tried to reverse it, but the problem is availability of the drug was an issue. We had only 400 milligrams. So we gave the bolus dose because that's what was available in our pharmacy at that time. Thankfully, after the loading dose was given, we took the patient up for a lower GI scopy, and this is where you could see a grade 1 internal hemorrhoids in there in the top picture, and you could see that the active bleeding had actually stopped. And because the patient had cirrhosis, somebody might say, hey, hold on a second, it wasn't lower gastrointestinal bleeding at all. Did you have a look at the top end? And actually, we did look at the top end, and there was a grade 1 variceal, but it was not actively bleeding, so we knew the bleeding was coming in from the lower gastrointestinal bleed, which was actually coming from a rectal ulcer, which was above the anal verge. And having given just the bolus dose of Andexxa alpha in this particular case, actually had stopped the acute bleed, and the patient was discharged 5 days later. So another case of GI bleeding. A 90-year-old female, hypertensive, CKD, chronic DVT, for which she was on apixaban 2.5 milligrams twice a day. Admitted to the ER for a pneumonia, goes admitted under internal medicine, and then subsequently develops an upper gastrointestinal bleed. The last apixaban dose was in the morning prior to her arrival to the ER, and as standard care, IV PPIs was given, but because the hemoglobin had dropped quite significantly, we started some blood transfusion. But the patient progressively worsened despite that and became hypotensive, lactate of 8, and the patient was deemed unstable for an urgent upper GI scopy. So lo and behold, what came to our rescue was Andexxa alpha. We gave Andexxa alpha, and you can see it was almost more than 12 hours since the patient presented to us, and by the time the patient received it, so we gave a low-dose regime. Again, we only had limited availability in the pharmacy, and I'm hoping subsequently we had better availability because we were starting to use this drug, and the bolus dose again made the effect, and this patient was discharged 12 days later. And what was more important is this patient never had an endoscopy because the bleeding had stopped, and the gastrointestinal team decided this patient we didn't have to undergo unnecessary procedure anymore, and they were able to discharge her. This one happened this year, a 98-year-old male, hypertensive, end-stage renal disease, and coronary artery disease, for which the patient was on rivaroxaban 10 milligrams, admitted to the ER with melena, coffee ground aspirate. Patient became quite hypotensive, and the last dose, as we know, was taken more than 8 hours ago. So patient had an urgent endoscopy in the ER, and one of the consultants who performed the endoscopy is here with us in the audience. And this is what it showed, and I'm sure she's smiling and she remembers this case. Had a large bleeding ulcer, and you could see the hematine stain and the fundus on the endoscopy picture, and basically they did two things. One, they put a clip over scope, and they did a hemospray on it twice to try and control the bleeding. And in discussion with the hematologist, because they suspected it was a big vessel that is actually bleeding, they started this patient on Andexxa alpha. This patient received a lowering dose of 400 milligrams and the infusion dose subsequently over 120 minutes of 480 milligrams as well. To see that if the patient actually settled down, this patient went into IR, and they went and looked at it because the concern was this patient was bleeding from the left gastric artery. And that was a concern. And if this patient bled again, this patient could have actually had a massive hemorrhage, and we may have lost the patient. IR does their test, and they found out that the bleeding had actually stopped, and they were quite comfortable. So that's why this was a combo treatment. You know, this is the upper GI and lower GI kind of algorithms that comes out from the British Society of Gastroenterology, and you could see on the left-hand side in the upper GI or on the right-hand side, they talk all about resuscitation, risk assessment, but the treatment does not have Andexxa alpha on the previous ones. However, if you move on, you could see subsequently both the British Society of Gastroenterology and the European Society of Gastroenterological Endoscopy have said in patients with hemodynamic instability who are on DOACs, particularly if they are on apixaban or rivaroxaban, consider the use of Andexxa as a reversal agent. So their guidance have also actually changed. So it just goes to the point that we using Andexxa in our GI cases actually has been the right decision for those ones. Let's look at the other presentation, which is about 19% of the presentations are intracerebral hemorrhages. We have a 74-year-old female, hyperlipidemic, AF on rivaroxaban, presented to us with an altered mental status, was having seizures, had vomited prior at home. What then we teased out was this was actually a provoked hemorrhage because the patient had a fall 2 days prior, and the patient had sedatives, antiemetics given, and we found out that the last dose of rivaroxaban was more than 8 hours prior. And the patient was intubated, sent in for a CT scan, and you can see on the CT scan, the patient had like a 4-centimeter frontal hematoma, subcortical hematoma in there with a little bit of edema surrounding that bleed and a bit of a midline shift in there. And this patient, in discussion with the hematologist and the neurologist, was given Andexxa alpha, a low-dose regime, and this patient was reviewed by the neurosurgical team, and their repeat CT scan showed no progression of the hemorrhage, and the patient did not require any further neurosurgical intervention. The ICU stay also kept minimal for 4 days, and the patient was discharged home 9 days later. The next one was even more interesting. It's a 79-year-old male who has history of AF, diabetes, and hypertensive on rivaroxaban for AF. Last dose was in the morning, felt dizzy and had a fall at home, vomited, confused, severe headache, arrived in the ER at 9 p.m. GCS started to drop, and this patient was intubated and sent in for a CT, and you could see a significant bleed in the brain with midline shift. This patient needed to go to OR, but the patient was anticoagulated. We had a problem. And the problem, one of the things was we had only 200 milligrams of Andexxa alpha in our pharmacy at the time. My pharmacy colleague is sitting in the back, and I'm sure he's now stocked up a little bit more. So what we did with discussion, this is again, some questions might come up with, can you mix Andexxa alpha with PCC? In this case, we decided because this patient needed to go to OR, otherwise this patient was not going to survive. So the patient had bolus of Andexxa alpha, 200 milligrams, a subsequent 1,500 units of PCC, and once patient finished the OR, we managed to get the rest of the Andexxa alpha from our sister pharmacy, and the patient had the high-dose regime to ensure that this patient does not have a rebleed or continue to bleed because this patient had a big craniotomy. And the repeat CT scan 8 hours later proved that what we did was the right thing, and there was a significant improvement in the CT scan, and the patient was discharged home after 20 days, and she had the DOAC restarted about 4 weeks because that's the kind of a time frame they wait for before they restarting DOACs. So, having looked at these cases and seeing that Andexxa alpha is helping us in our cases which are pretty critical on arrival, how do we go about it? So it comes as 200 milligram vials, and each of the pack comes as 4 single-use vials, and you give it the bolus dose. If it is 400 milligrams, you give it over 15 minutes. If it is 800 milligrams, you give it over 30 minutes. And then you give your infusion, which is if it is going to be 480, you give it over 120 minutes. If it is, again, the same dose, if you higher dose of 960 milligrams, you again give it over 120 minutes. Only thing is the amount of milligrams per minute is what changes. It's quite a stable drug. If you had mixed it, and if you're not going to use it immediately, it's quite stable at room temperature for about 8 hours. If you store it at 2 to 8 degrees, it's stable for about 16 hours. And even if it is mixed in a bag, you can keep it for about 8 hours. So it's not something that you mix it and you have to discard it immediately. So it can be used if needed. And there are 2 types of regimes we talked about, a low-dose regime or a high-dose regime. And the low-dose regime, 2 things comes into play. The dosage of the drug, whether it is apixaban or rivaroxaban, how much is the patient on, and the timing of the dose, when did they take. These 2 in combination, the 2x2 table will tell you what sort of a regime you need to start on these patients. So if somebody is on apixaban low dose, say less than 5 milligrams, and rivaroxaban less than 10 milligrams, and if they've taken the drug more than 8 hours prior, then you give them on a low dose regime. If they are still, apixaban is less than 5 milligrams and rivaroxaban is less than 10 milligrams, and if they are taken it less than 8 hours, but still because the drug is only a low dose, you still keep them on a low dose regime. When do you go into a high dose regime? You go into a high dose regime, particularly if you don't know when they've taken, how much they have taken, and if they've taken a high dose, for example, apixaban more than 5 milligrams or a rivaroxaban more than 10 milligrams, then you would go on a high dose regime to treat them. 80% of the cases, and like you see even from our own, except for the neurosurgical case, everybody was on a low dose regime. And that's what real world evidence still shows, that 80% of the cases currently have received a low dose regime and still have been successful in reversing their anticoagulation. And this is the dosage regime for a low dose 400 milligrams at a target rate of 30 milligrams per minute, and the follow-up infusion over 120 minutes of 4 milligrams per minute. And a high dose will be 800 milligrams at a target rate with 30 milligrams per minute, and an 8 milligram per minute of infusion over 120 minutes again. And the number of vials you're looking at is 5 and 9, because it comes as 200 milligrams per vial, and that's why it is a little bit oddity of 5 and 9. So, Professor Zohair asked us, what is the protocol that ER physicians have a protocol? And this is a very busy slide. And the reason is ER likes to keep it simple. I said my attention span is small, so I need to bring something. And I know if it's DOAC, I'll go to the left of the algorithm. If it's warfarin, I'll go to the yellow color in the box. If it's something in the middle, I'll go somewhere else to look at it. And that's what we did. And this is a busy slide. So particularly for DOACs, we decided to show you this, where if the patient has a major bleed, what we do is we do the standard things about resuscitating the patients. You also look for other comorbidities. Do the patient has thrombocytopenia, uremia, liver disease? Should I be looking at other things which I need to correct? And subsequently, you think is, what is the DOAC that the patient is on? And subsequently, if they are on rivaroxaban or apixaban, and if they have a major bleed or a critical site bleed, then you would aim to reverse them. And we talked a lot about these reversal agents, which is Andexxa or Andexanet alpha, either a low dose or a high dose based on the timing of the drug that's taken and the dosage of that taken. On that note, ladies and gentlemen, thank you for your time.
Thank you, Professor Jay, for this nice cases and presentation and the summary of the management of major GI bleeding and ICH in patient with DOAC in emergency. So I see you have your team here, so we cannot comment on any of the cases. One of the questions that comes up is who prescribes the Andexxa? Is it yourself with discussion with the hematology, or?
So as it currently stands, we are discussing with our hematology team to actually prescribe the Andexanet alpha. The future would be is once the protocol is written and it's approved by our committee, then the emergency physicians will start prescribing it, and that's the aim, because time is of the essence for us and we don't want to delay. It happened with atrial fibrillation for us when we started using vernaculant, and vernaculant was an expensive drug, and initially it was with discussion with the cardiologist, whereas subsequently we moved and started prescribing in ER. Similarly, that's the aim for Andexanet alpha as well. We are now discussing with the hematology team, but subsequently, once the protocol is up and running, it'll be the ED physicians, because time is of the essence.
Okay, thank you. I'll just remind you, if you have any questions, you can scan the code, and we'll have a discussion later on. We are running late, and as the next session says, every moment matters, so we have to move from this session to the next session. I would like to thank the speakers, Dr. Hazza, Dr. Professor Asiri, and Dr. Jay. And we move on to the next session. Dr. Rasha Ahmed will be chairing the session. She's the president of Society of Emergency Medicine and consultant emergency physician at MedClinic Parkview Hospital. Dr. Rasha.
Welcome to the stage, Dr. Rasha Ahmed.
Assalamu alaikum, everyone. Good evening. It's an absolute pleasure to be here and to be part of this multidisciplinary team. I think they mentioned most of the specialties that are here, but I also want to acknowledge there's critical care, there's trauma, there's so much more. And this is an amazing gathering for all multidisciplinary team. And thank you for bringing us together, colleagues who I've actually known and worked with, and new colleagues that I'm gonna, inshallah, interact today with. So far, we've been really having an amazing session. So we talked about time is brain, and where we had really a brief of the scientific evidence behind anticoagulation and the reversal and what is there. And we were very inspired by the code ICH, right? So we have a number of codes in the ER, and we love them, because these codes always streamline care. So we're looking forward to get these codes, inshallah, implemented. Followed by the turning point. Nothing triggers us like actually real cases, right? So we started with a video of Sultan, and our colleagues actually shared real-life experiences where they had major bleed, and they actually used the medication to try and help the patient. Now we will talk, how do we make this happen? So this session will be about every moment matters. And I'm going to have with me here in the stage 3 of my colleagues that I would love to introduce. The first is Dr. Mohammed Al-Sheikh. He is the Deputy Director of Cancer Center of Excellence at King Faisal Specialist Hospital and Research Center. He's an adjunct professor in internal medicine and hematology at Al Faisal University, acting chair of hematology, stem cell transplantation, and cellular therapy department, running several clinical trials on thrombosis and hemostasis. With me, I will have Professor Mazen Taha, who is the chairman of gastroenterology and hepatology at Tawam Hospital, as well as the clinical professor of medicine at the Faculty of Medicine at UAE University. And finally, Professor Hani Sabur, assistant professor of cardiology at Brown University Medical School at Rhode Island, USA, as well as a consultant cardiology, electrophysiology, advanced heart failure, and pulmonary hypertension in Abu Dhabi, UAE. Many of them are actually colleagues that taught me, I worked with, so it's truly inspiring to be here on stage with them. So I just want to ask everyone, door to needle, what does this remind you of? Right? Stroke in the past. Now let's see, how are we going to talk about it here with a major bleed? So with this, I would like to invite all of the speakers on stage. And first, I'm going to hand over to Dr. Mohammed Al-Sheikh to start his presentation on optimizing time to reversal.
Welcome to the stage, Dr. Mohammed Al-Sheikh. Welcome to the stage, Professor Mazen Taha. Welcome to the stage, Professor Hani Sabur.
Bismillahir Rahmanir Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, ladies and gentlemen. It's my pleasure and honor to present today and share my experience among my teachers, my senior colleagues. It's really inspiring, and the previous presentation and previous speakers made my task easy because my presentation is complementing the previous topics, now talking about very important concepts as mentioned by the moderator, Dr. Rashid, that we know time to door to needle, this is for ischemic stroke, for administering of TPA. Now we are moving to a new concept about time or door to needle for reversal of anticoagulant therapy. Without further ado, I will go to my presentation. Just to, this is the outlines of my presentation, and the most important, introducing the new concept of optimizing door to needle time for reversal of anticoagulant therapy. Also going to talk about the protocolization of management of or reversal of anticoagulant therapies. This is important. We know that intracranial hemorrhage, it is not the most common major bleed. However, it's the most devastating. It's highest mortality rate compared to other. We know that GI hemorrhage is more common. Other bleeding, like we know DUAC, by the way, increase the risk of what we call mucosal bleeding, GI bleeding, menorrhagia or heavy menstrual bleeding. However, it can also increase the risk of intracranial hemorrhage, although in the clinical trials, it was less than vitamin K antagonist, about 50% and less. But still, it's rare, but however, it does occur, and when it occurs, it is associated with high mortality and morbidity. So this is an important concept to talk about the hematoma expansion. That's why we are emphasizing door to needle, because the hematoma expansion. With hematoma expansion, usually, as you see here, if you have 3 cc intracranial hemorrhage, the score or the mortality is 0. If you have 77 or 42 cc, the mortality is 72% after 77 minutes. And it was mentioned before, one of the key performance indicator, or its to time or door to needle, is 60 minutes, which is, by the way, a new concept. Still, the paper was presented by Stephen Meyer. It's a paper that submitted for publication. So this is critical. Time in the brain, as we mentioned before, is very important. As the hematoma expand, mean it more tissue damage, more disability, permanent disability, and more mortality. And again, this is important. 1 in 3 patients have significant, hematoma expansion in the first 3 hours of intracranial hemorrhage. So again, it's very important. Blocking hematoma expansion as quickly as possible is an important goal of intracranial treatment, intracranial hemorrhage treatment. So this is a patient presented with, intracranial hemorrhage. So we have the ABC care bundle. ABC care bundle, the first one is anticoagulant reversal. So, and blood pressure lowering, and the C, it's hematoma evacuation or referral to neurosurgery if the case is candidate. So by implementing the care bundle pathway, you're going to improve the outcome of intracranial hemorrhage. So this is the ABC care bundle. As I mentioned before, is anticoagulant reversal as soon as possible. Preferably, door to needle is less than 60 minutes. Blood pressure, IV, medication to lower blood pressure, and also the prompt referral of appropriate or candidate cases for neurosurgery for hematoma evacuation. So this is, from the onset of symptoms to the, presenting the emergency department. So multiple, channels or milestones. So scene to door, and door to scan, and scan to treatment. There are, I'm just presenting some quality improvement, project that showed, the targeting, what are the common, cause of delay of this, treatment is delay in the imaging. So we need rapid brain imaging on arrival. Again, you need quick decision treatment by establishing last dose. This is important of the protocol. Protocolization, so if you have a protocol, you need a multidisciplinary approach. As a thrombosis or hematology, if I put the protocol, and the protocol is not, done meeting or line up with emergency, critical care, and cardiology, and other colleague, it will not work. So this is very important to have quick decision by putting, a protocol. Also, the protocol should be simplified. Very important. I think always simplicity is electricity. So if we have simplified protocol, algorithmic approach, so gonna make it easy and easy access to treatment. By easy access, so drug to be available in the emergency, should be stocked in the emergency pharmacy or the ICU pharmacy. So like in our hospital, King Fahd Medical City, we have a pharmacy for each, like critical care, CCU, ER, so should be stocked in these, critical care units. Talking about door to needle, starting by the vitamin K antagonist. As we know that vitamin K antagonist warfarin is less commonly used compared to factor 2 inhibitor, rivaroxaban, apixaban. However, there are compelling indications to use it, like mechanical heart valve, patient with interstitial disease, like the previous cases you presented. Patient with interstitial disease on rivaroxaban definitely they will develop complication. So there should be, the right clinical, or approved indication. So very important. We know vitamin K antagonist is still used, as I mentioned, in addition, antiphospholipid syndrome, mechanical heart valve, and interstitial disease, or patient who failed, vitamin K antagonist or warfarin should be prescribed, DOAC. So what are the, this is a quality improvement project about 55 patients, including in final analysis. The primary outcome was a scan to needle time. So this is from scan to needle time. It was the 3 key changes to reduce delay. The most important one, that PCC should be stocked in the emergency department. I think this is applicable also for Andexxa alpha, should be stocked in the emergency department or critical care unit. Point of care INR device, this is for, warfarin. Point of care for, DUAC. This is a work in progress. We don't have it for the time being. Also, standard protocol to deliver BCC without hematology referral for every case, as recommended by the American Stroke Society guidelines. However, this is easy said, difficult done. To be, release restriction from hematology or thrombosis, I think at the start going to be difficult. But, as mentioned by Dr. Hazza, I'm really proud to Dr. Hazza, he was my teacher. It's a bit difficult, but I think it's not impossible. Just to make it a protocol that to restriction, not only to hematology thrombosis, should be critical urine, probably later on in our hospital to emergency physician. So start stepwise fashion rather than to release restriction all of a sudden. I think going to be, this is excellent if we release restriction because, going to bypass many consultation for different subspecialty to get the drug. By that time, we know time is a brain. The patient already have devastating, complication from intracranial hemorrhage. So this is, as we have seen, so there is a remarkable reduction. Is the laser working? Mm-hmm. Is it working, the laser, or? Okay, so we can see here the door to scan time. It was reduced after, implementing this, as I mentioned, and the most important, door to needle time, it was also significantly reduced, both comparing, before implementing these, key changes. This is now moving to door to needle time for factor 2 reversal, which is the dabigatran. I know the dabigatran, this is DUAC, factor 2, it is factor 10 inhibitor, factor 2 inhibitor. It is less commonly used compared to rivaroxaban and apixaban. Talking about in Saudi Arabia, I don't know, is it the same in, in Emirates, because more side effect, more GI bleeding, more intracranial hemorrhage. So it is now less commonly used. So this is again the direct antidote. It's idarucizumab. It is monoclonal antibody. So the dose, it's again should be stocked in the emergency or critical care pharmacy. Should be given about 5 milligram and packaged as 2 vials, and no reconstitution needed, and can be transferred to a syringe for bolus and can be delivered as infusion. Regarding, improving door to needle times, factor 10A inhibitor for reversal, this slide, it was repeated multiple times. Again, with repetition comes perfection. Just to mention, it depends on 2 factors important: the dose, last individual dose of the DUAC, factor 2 inhibitor, whether it is apixaban or rivaroxaban. So we have, if it is for apixaban, less than 5 milligram, or more than 5 milligram, for rivaroxaban, less than 10 or more than 10. By the way, there are various doses for rivaroxaban. We have 15 and 20. This is for VTE treatment. Again, 10, we have it for, let's say, VTE prophylaxis, post, orthopedic procedure, and also for use as low-dose DUAC for secondary prevention and maintenance anticoagulation. We have 5 milligram for, again, acute coronary syndrome. We have 2.5 for peripheral arterial disease, so we have multiple doses. And we have apixaban 2.5 dose, and we have 5 milligram, and we have 10 milligram. So it depends on the dose. If it is less than 8 hour, and more than 5 milligram, we give high dose. Or if it is unknown, so unknown, time since last individual dose, we give high dose. I think this is more common scenario that patient, they don't know, let's say, if presenting very critical situation, and we don't know what's the last time individual dose, so we have to give the high dose. Again, the same for rivaroxaban. There is another DUAC which is more commonly prescribed in Saudi Arabia. It is edoxaban. Edoxaban, again, it can be used for it, but it is off-label, by the guidelines. So it is factor 10A inhibitor as well. This is important that there's another quality project or quality improvement project, a pre-hospital, pre-alert for anticoagulant. Patient have, in the system, if you have electronic system, for our hospital, EPIC, so by just putting pre-hospital, pre-alert patient on anticoagulant, so there is a quality project that was started on March 2018, and they found if the patient have pre-hospital, pre-alert, and come to the ER, usually door to scan, it was reduced by 30 minutes. If the patient have no alert, I think this is another great quality project that you alert all these patients. Like, patient in anticoagulant, they have a bracelet, bracelet in their arm or wrist. This is important, the system. It's going to reduce the door to scan time by, this is we are not using. This is, again, some of the project it's great ideas for us to implement before I share with you this data. And again, the quality improvement project I discussed before in Salford Hospital, they reduced mortality from 30, here mortality before and after, from 35% to 24% by implementing all the quality project I mentioned before. So there is important, we can see outcomes after implementing quality improvement project. And if you have intracranial hemorrhage, if patient on anticoagulant, and the patient if have a hemorrhage secondary to or major bleed secondary to anticoagulant therapy, so you have the cost about $96,000. If the patient without major bleed, it's about 49%, about almost 50% less. The highest cost is with intracranial hemorrhage, about $150,000, followed by GI hemorrhage, and then for other. So important that this is all-cause adjusted healthcare, almost 2 times higher for patients who experience a major bleed versus without a major bleed. What about the cost? Some people think it's costly drug, Andexxa alpha. Yes, it's costly drug, but if you it's cheaper than 4-factor BCC as you compare the price, 13 versus 9,000. However, if you look to other important parameter like ICU stay is longer with 4-factor BCC, mechanical ventilation, as well as neurosurgical intervention. Overall the cost about saving about 5,000. Again, there is a projected cost saving about 792 over 3 years, because this is a business impact model. It was done over 3 years, showed cost saving about 792,000 over 3 years. This is very much too much cost saving. Again, if you have Andexxa alpha, the favorable clinical outcomes over 4-factor BCC in the treatment of intracranial hemorrhage and acute with 33%, as was demonstrated in the previous slide, 33% lower mortality rate. So it was a risk as I talk about hematoma expansion, it was less, about 31% with 4-factor BCC and 12.5% with Andexxa alpha. ICU is less, risk of mechanical ventilation, risk of neurosurgery, and overall the mortality rate was important. It was about 33% lower mortality rate. And what about, Andexxa alpha has the potential to optimize the management of factor Xa inhibitor related to major bleeding, address an important unmet need. As we know, the prevalence of, DOAC use is increasing, and we're seeing more hemorrhage. I remember this when we started to use DOAC 2011-12. Most of physicians were skeptical. Oh, we don't have antidote. This is the first, that resistance and reluctance from our colleague, we don't have antidote. I think this is important. Now we have antidote. Yes, came late, but this is to come late better than not to come. So this is important drug that to refers. Actually, I don't have it in our hospital. But if, Dr. Hazzah, he gave 8 patients, you gave 8. If we have it in our hospital, I'm just retrospectively going backward over the last 10 years, we have given maybe 20 patients, because our hospital is a huge hospital, a referral center for all, MOH hospital in Saudi Arabia. So also supported by clinical efficacy and safety data, as was presented by Professor Stephen Meyer. We have Andexxa A, Andexxa R, Andexxa 4, so overwhelming body evidence and wealth of data. Also recommended by clinical practice guidelines and expert consensus. Many guidelines. I went through all the guidelines. All they recommend Andexxa alpha as first choice antidote for factor 2 inhibitor. If you don't have Andexxa alpha, you can use other alternative method like for factor B6. But this is the first and the only available reversal agent for factor 2A inhibitor. So this is very important. Let's have all the guideline and now about you cannot have any JCI accreditation without meeting their criteria. So the Joint Commission encouraged the use of DUAC specific reversal agent. So very important that they said anticoagulant have been named as second of top 10 medication involved in error incident causing death or serious harm. So serious and potentially deadly consequences related to factor 2 inhibitor associated bleed can be avoided with appropriate and timely treatment, and they encourage to use a protocol also with national patient safety goal for anticoagulant therapy. Again, they say all hospitals use approved protocols and evidence-based practice guidelines for reversal of anticoagulant. So all these recommendation for this. I know this is a busy slide. Just to summarize it, if you have a patient who presented with life-threatening bleed, was factor 10A inhibitor taken within the past 18 hours. I know you have seen the that less than 8 hours, more than 8 hours, but the cutoff up to 18 hours you can give. So highly likely or documented, then was reversal with Andexxa alpha considered. Yes, we have to check the indication consistent with the guidelines for Andexxa alpha. As mentioned, Dr. Hazza, make sure not to give it to other minor bleeding or clinically non-relevant major bleeding. It has to be a patient-appropriate indication. So this is important, and was Andexxa alpha prescribed as appropriate dose and approved in timely manner? Was timely receipt and verification of pharmacy order, timely preparation delivery? Was the dose administered within the designated time? Was hemostasis achieved? As we know that achieve about 80 to 90% efficacy. Were adverse events documented like thrombosis? We know this is it's common with for factor BCC and not seen with Andexxa alpha. Was there documented plan for restart of anticoagulation? Was the patient discharged home or rehabilitation? This is bringing us to another important topic. After managing this patient, resumption or restarting of anticoagulation. It's complex decision. It is multidisciplinary team. Depending on the anticoagulant use, depending on the anticoagulation, we have seen patients, they have a provoked VTE, should be treated for 3 months, the patient on DUAC for 2 years. So this, if you have bleeding, reverse the bleeding, should stop. If the patient have indication for anticoagulation, like extended anticoagulation, lifelong, then you need to make sure, depending, is it AFib? Is it mechanical heart valve? Is it a VTE? So it is not easy. It is a multidisciplinary team. However, intracranial hemorrhage, according to the American Stroke Guidelines, from 4 to 8 weeks. 4 to 8 weeks. If you have atrial fibrillation, patient mechanical heart valve, we usually resume earlier, up to 2 weeks. For a patient who have VTE, we can start also, for intracranial hemorrhage, the same for VTE patient, minimum 4 weeks. So it depends. When you start, it have to be approved by neurology, neurosurgery. Okay, this is very important. Thrombosis in neurology. So it is multidisciplinary team task. This is important to address. And this is our protocol to have King Fahd Medical City protocol for factor 10 reversal. So we have it. We bought all reversal agent. Prothrombin complex concentrate for factor BCC. We have also included fresh frozen plasma. FFP is a drug. We have to be given the right dose for the patient, okay? It's like 10 to 20 ml per kg, average 15. Again, we have other like protamine sulfate for reversal, protamine for low molecular heparin and anti-heparin. We have Again, this is for, reversal agent for DUAC, direct, specific reversal agent for, we have monoclonal antibody, idarucizumab, and we have for factor 10A, inhibitor Andexxa alpha, rivaroxaban, apixaban, edoxaban, and this is the same that we are using this protocol. It's important that, restriction. I know this is currently in our hospital because the Pharmacy Therapeutics Committee mandate, if you introduce this medication at the start, initially should be restricted to hematology, to thrombosis, neurology, critical care. I think ER maybe, because ER should be, as you mentioned, I'm really happy about, I hear that involvement of ER, it's really great, not like our hospital. I think they can be empowered and can be part of our team. Great, success cases, very, inspiring cases. Thank you very much. With this, just to conclude and wrap up, that important, best practices can guide the use of Andexxa alpha across a variety of practice setting. Most important, multidisciplinary team approach. It has to be applicable to all institutions, small to large size. If you don't have the, the abilities or capabilities, should be, small institute, they should have mechanism to refer to tertiary care hospital. This is very important. Also, they have individualized to patient prescription, patient presentation. So important, as I said, institutional protocol and multidisciplinary team and education of all the prescribers. We need to educate. This is very important, session to educate prescribers about Andexxa alpha. And it has to be, as Dr. Hazza showed in the system, they have power chart. We have, EPIC to put it best physician, prescribing, practice, to have a protocol when you give low dose, give high dose, when you restart anticoagulation, etc. So very important to have and implement monitoring process to periodically review utilization of Andexxa alpha. With this, I will conclude my presentation. Every moment matters. Thank you very much.
Thank you very much, Dr. Mohammed Shif. My question, actually, you talk about protocol. What do you think that this is actually should be, so develop something like clinical pathway in every hospital, which is include all of the specialty who are available in this hospital, like as ED, ICU, gastroenterologists, cardiologists. Do you think that what we need something like clinical pathway more than protocol, which endorse for one specialty?
Yes, thank you. Clinical pathway and the protocol, they work hand in hand. I agree with you. At CAFE MCR, our hospital, our protocol, we are trying, to expand. Now it is at the MOH level. However, this is early phase. We are, there is always, potential room for improvement, and I think it can be more illustrated with algorithm, clinical pathway. So not yet finalized, not yet approved. It is in the approval process. Yes, we can add, make it a clinical pathway in addition to the protocol. Okay. Because MOH, they need a protocol for VTE prophylaxis, VTE treatment, for reversal, for etc. This is one of the, let's say, unmet need, okay, and to close this gap, to have a protocolization for reversal of anticoagulant.
Thank you very much. Thank you very much, Dr. Mohammed Shif, for the excellent interview. So we go further. I remember actually for 30 years I was resident in internal medicine in Berlin, and it was one of the dogma we are not allowed to prescribe anticoagulant in the people above 80, as that was contraindication and malpractice. With the time we are getting more and more liberal, but actually they bring more side effect with itself. We understood, we saw that this is the most indication is arrhythmia, the most complication is GI tract, but the life-threatening complication intracranial hemorrhage. That is we have to know. So because of actually the most of indication is arrhythmia, it's my pleasure to introduce Dr. Hani Sapoor. He is experienced cardiologist and with wide experience in electrophysiology. He talked about the dose and houses actually manage the anticoagulant. And just want I ask him, that's actually the first question, because the most complications, GI complication. First question from our internist or hospitalist, when we can resume the anticoagulant after GI bleeding. Probably can Dr. Hani answer. Thank you, Dr. Hani, for your comment.
Okay, thank you very much. All of the previous presentations have been very extensive, and you're probably going to see some slides repeated, so I apologize for that. So rather than talk about the medication that we're talking about today, I want to talk about why we need to use it. It is to enable DOAC utilization in high bleeding risk patients. Obviously, our objective is to treat what? Is to prevent stroke in patients with AFib, right? And these are the same risk factors that increase the risk of bleeding. If you are older, if you have heart failure, if you have coronary artery disease, vascular disease, kidney disease, inflammation, you will have a very high ischemic risk, and you're going to have an even higher bleeding risk. Does that mean you don't give the anticoagulation? The answer is no, but you have to deal with the consequences if and when they happen. So the DOACs have been revolutionary, as you know. They have completely changed our response to warfarin. Every single DOAC study, and I didn't include edoxaban here because it's exactly the same, lower risk of major bleeding compared to well-controlled warfarin. And more importantly, GI bleeding, while it was slightly elevated with rivaroxaban and dabigatran, again, we're talking about all GI bleeding, not fatal bleeding, not severe GI bleeding. So in reality, intracranial hemorrhage was the unique thing that reduced with the DOACs. That meant that more patients are now eligible for DOAC utilization, including the elderly, including patients with CKD. So we should not be withholding DOACs because of concerns of bleeding. In fact, this is well stated in the guidelines. On the other hand, even though there is less intracranial hemorrhage, somewhere between 50 to 60% less with DOACs, it still happens. So you have to have a tool, you have to be prepared. So we know that AFib, non-valvular AFib, is increasing in our region. We have a high risk profile. There is a very high risk population out there, right? Hypertension, diabetes, dyslipidemia. Very few people have a single risk factor. High prevalence of comorbidities means that we have a lot of diabetes, a lot of coronary artery disease. These patients will not qualify for monotherapy or without DOACs. So as we get older, AFib increases and stroke-related bleeding increases also. That is the logical conclusion of this population. In addition, when patients are over 70 years old with AFib, the majority of these patients are going to have coronary artery disease, which means what do they need? They need to be on antiplatelet therapy as well. All of these amplify the risk of bleeding. But again, the message here is don't withhold the DOACs, have a treatment to treat your patient and prevent stroke. So remember that DOACs universally have been shown to reduce major bleeding and in fact all-cause mortality. These are real-world data, not from the randomized studies, which has obviously led to a significant increase in the prescription of DOACs and a decrease in the prescription of warfarin. That makes sense. It's simply a safer and more effective agent. Now, in the UAE, there's a continuous increase in the rate of utilization of apixaban and rivaroxaban. Edoxaban is also coming on board. There's less warfarin as well. So what is the primary objective in treatment of AFib? So there's two new guidelines that have been released in the last 2 years. They are called the integrative approach to atrial fibrillation. And you see at the top of this large pyramid with a lot of elements is what? Stroke prevention. Stroke prevention. Reduce stroke. Palpitations is not the reason you treat AFib. It's because they have a risk of stroke. And again, if you look at the ABC pathway, which was very nicely presented earlier, but this is focused on what? Anticoagulation to avoid stroke. And it's basically a balance between bleeding and anticoagulation. So obviously, there is a balance here. If a patient has cardiac disease, basically has coronary artery disease or had a PCI, you're going to give them an antiplatelet agent to prevent thrombosis of the stent, but of course you expect there's going to be an increase in bleeding, right? That's logical. You can't go without giving patients with PCI antiplatelet therapies. Same story, stroke versus bleeding risk in atrial fibrillation. You have to balance stroke risk, which is high, versus bleeding risk, which may be higher if the patient's population suggests that. Now what happens if you have all three? A patient who has coronary artery disease, and atrial fibrillation. What's then? Well, it's again another balancing act. You have to balance the risk of stroke, the risk of recurrent ACS and stent thrombosis versus the risk of bleeding. The aim is to reduce the risk of thrombotic events with an acceptable increase in bleeding complications. You cannot prevent bleeding except by stopping all medications. Is that reasonable? Of course not. That's not why the patients are there. So, this is, again, a very extensive list of risk factors that you're familiar with, which we summarized into the CHADS-VASc score, right? But is the CHADS-VASc score the only group of risk factors? Absolutely not. In fact, there are so many others, including impaired renal function, sleep apnea, amyloidosis, echo, left atrial enlargement, LVH. But we only account for the CHADS-VASc score in our calculation because that's been validated. Remember, that's not the only thing that increases the risk of stroke. Now, what about bleeding? This is an extensive table that tells you all of the possible risks of bleeding with oral anticoagulant and antiplatelet therapy. Some of them are non-modifiable, but some of them are, including elevated blood pressure, NSAIDs, alcohol, hazardous hobbies, bridging, uncontrolled warfarin, inappropriate dosing of OAC, and this is our responsibility. So, the HAS-BLED score has been proposed to give you some guidance on how much the bleeding risk is in every patient. So uncontrolled hypertension, renal or hepatic function, previous stroke, including previous hemorrhagic stroke, mind you, bleeding history, including thrombocytopenia. However, remember that the HAS-BLED score is not utilized to guide anticoagulation decision. You cannot use a high HAS-BLED score as an excuse not to treat the patient. It's a class 3A. You can't do that. And I see a lot of times this is happening. Again, labile INR, elderly, drugs or excessive alcohol or non-steroidals. Yet again, the HAS-BLED score is not used to prevent anticoagulation. It is used to change the modifiable risk factors and be prepared for a bleeding event. So, continuing anticoagulation is essential, even if the patient is in sinus rhythm. I'm an electrophysiologist, so after cardioversion, ablation, or AFib surgery, maintenance of normal rhythm does not mean stopping anticoagulation, right? I think this is a very key point that's been very well emphasized in the guidelines. So, what are the situations where immediate anticoagulation reversal? These are all unpredictable and time-critical situations. That's why we need to be very aware of this guideline. That's why we have to be protocol-driven and very quick. So car accidents, urgent surgeries, cardiac emergencies, falls, and trauma. Unpredictable. You can never tell when this is going to happen to your patient, even though they've been stable for years. So to summarize, when will you need to reverse anticoagulation? Very severe bleeding. Critical organ bleeding, particularly CNS, to a lesser extent GI, more with CNS, motor vehicle accidents, and any urgent surgery that cannot be delayed for 12 hours. Where did I get the 12 hours from? It comes from the half-life of these agents. They have all universal short half-lives, and therefore, if there's normal kidney function, you wait 24 hours, that's 50% half-life bioavailability, and most of the patients will survive. However, there are still certain situations. Urgent cardiac surgery, neurosurgery, acute abdomen, life-threatening bleeding such as intracranial, critical organ bleeding, eye bleeding, or closed space, a retroperitoneal or pericardial bleeding, or a compartment syndrome in an orthopedic patient, yes? And ongoing bleeding, you've tried your best, it's not getting better. The patient continues to bleed, you can't let them go into hemorrhagic shock. So what is an ideal specific DOAC reversal agent? It is an agent that acts immediately, targets only the NOAC, provides complete reversal, easy to use with a sustained effect, predictable, and most important, no procoagulant effect. Novo 7 was mentioned, and I have a terrible experience with a patient who had a bioprosthetic valve and atrial fibrillation and was given Novo 7. At the time, we didn't have any reversal agent. Yes, the bleeding stopped because of the intracranial hemorrhage, but what happened to the bioprosthetic valve thrombosed and the patient went into a cardiac arrest? So you really should not be using prothrombotic agents. You take the DOAC out of the equation and you concentrate on the emergency resuscitation or the procedure at hand. So There are non-specific measures that are available. For dabigatran, we used to use dialysis, actually, in the past when you had massive bleeding. Stop and wait is probably the best, but it takes too much time and the kidney function has to be preserved. And then, of course, these procoagulant effects are quite dangerous. Again, prothrombotic risk, and remember, PCC is not specific, not immediately acting, and has a rebound effect as well. So this is actually from another study. This is the reverse AD study. But I only show you this. This is the idrusizumab because of the type of patients that were enrolled. Acute abdomen, bone fractures, joint abscess, incarcerated hernia, pacemaker implants, intracranial hemorrhage, need for aortic aneurysm repair and pericardial centesis, and spinal surgery, or even a heart transplant and LP. All of these cannot wait, and they happen quite frequently in general clinical practice. So we talked about a protocol, and I think it's very important to have a defined protocol, and it has to be necessarily simple. This is going to be seen by everybody, from your intern in the emergency room, to the consultant in the ICU, to the anesthesiologist. Everybody has to be able to read through this quickly. So if you have life-threatening bleeding, this is the new consideration. PCC is non-specific for dabigatran, idrusizumab, and now we have the Andexxa for apixaban and rivaroxaban. So we have to know these things, and we have to know where they are. In addition, you have to have cross-matched blood and replacement. This is also very important because you have a blood loss that you have to replace as well. Giving this agent won't create blood cells. It's only going to produce less further bleeding. So the European Society of Cardiology has a very nice pathway, which I think everybody has to look at. If the bleeding is severe, that's kind of important, or life-threatening, that's when you have to start replacing blood products. If the bleeding is acute and severe or life-threatening, again, antidote required, and you have to know how to use the antidote. Again, this antidote has 2 steps and 2 different pathways, which was very nicely explained by both speakers. So this is a very clever invention. It's not a monoclonal antibody, unlike idrusizumab. It's a decoy protein that actually binds with great affinity, so it sucks out the 10A molecule. It's not there in the circulation, and therefore allows thrombin regeneration and factor 10A activity to normalize. So it's a decoy. It tricks the actual molecule into sticking to it. Now, the ultimate measure, however, is halting or stopping clinical bleeding and preventing organ damage. So I'm going to go into the PCI business because I'm a cardiologist. I see this all the time. 3 in the morning, we get called. We have to come in and do a PCI, right? So there are millions of patients, probably about 2 million in Europe, who are going to get PCI, who also have atrial fibrillation. There's an overlap, as we said, between AFib and coronary artery disease. Why is such a big problem to have PCI-related bleeding? Actually, because if you have bleeding during a PCI, mortality has been shown to increase. Why? Because you have to stop the antiplatelet therapy after you've put in the stent. That's even worse than not putting in the stent. Plus, you have shock, stent thrombosis, inflammation. Mortality has been shown to increase quite significantly. In fact, there's a 5.2 in-hospital mortality rate with major bleeding in PCI patients. This is very bad, okay? So you really must avoid bleeding at all costs, in fact, if you have PCI. This has been the subject of multiple studies, in fact, looking at the combination of AFib and PCI. This is Redual, and this is the DOAC with DAPT, with Pioneer, and this is also the rivaroxaban. And the ranges requiring intervention are up to 85%. Why? Because you're using combination of your DOAC plus single or dual antiplatelet therapy. So you're now blood thin is like water. So what happens here is that the guidelines have come up with evidence-based medicine to shorten the use of triple therapy. We want to shorten it as much as possible. In fact, as little as 1 week in certain patients who do not have an ACS or have low ischemic risk. So really that's the point, shrinking the period of time. But of course, this window, whether it's 1 day or 30 days, bleeding will happen, and you have to be able to reverse it. So the studies that are now shown this include Compass, Pioneer, Augustus, Redual. These are RCTs looking at safety of the dual combination. If you delete the aspirin, do you get more stent thrombosis and less major bleeding? The answer is yes. Less stent thrombosis, less major bleeding. So I'm going to show you a case, and this is actually quite a bad case, actually, and there was a bad complication attached to it. So the 75-year-old guy with hip surgery about a week earlier presents with shortness of breath, intermittent chest pain, very elevated troponin. This is, of course, an ACS, had a prior stroke, an AFib with hypertension, dyslipidemia, and COPD. This is the medications. And this patient had new onset of chest pain. Was admitted to the heart center. I don't know if you can see, but there's actually ST elevation in the inferior leads right here. The patient actually was receiving intravenous heparin and aspirin on the way to the cath lab. The platelet count is 25,000, hemoglobin is 11. And then at the time, the patient has a non-compliant balloon in the proximal LAD. We inflate the balloon in the right coronary artery in the left main and gets a stent into the LCX. So without going into the details, this is a complex PCI. There's balloons being implanted and stents in both arteries back into the left main. And then all of a sudden we see this. You see that? This is blood. Blood where? In the pericardium. So we've actually managed to rupture the coronary artery, and this is a massive bleeding that's going to affect not only the coronaries and also the patient's hemodynamics. A stat echo is done, and you can see here there's a huge pericardial effusion, and the patient is already going into tamponade. The left atrium is collapsing, and the right ventricle is collapsing as well. So what do we do in this situation? We balloon occlude the breathing vessel, and we put in a pericardial needle and drain the pericardium. Okay? And then what we do is we do what's called a covered stent. This is a rare procedure, but you have to do it. Of course, the covered stent has a very large surface area, and it has a very high risk of what? Thrombosis, isn't it? So now we're really, really stuck. So for that particular purpose, this really requires very rapid reversal. So in addition to the mechanical occlusion, we gave protamine to reverse the heparin. The patient had the cover stent, and Andexxa was given as well at the standard dose. And of course, what happens there is that the patient's bleeding has stopped. So the patient, after the surgery, thank God, recovered, but we had a very difficult time, and the patient was actually switched from rivaroxaban to a low dose of dabigatran at the time of discharge. So one of the things that we have to think about that NOAC reversal is essential in interventional cardiology is during PCI. If you have a wire perforation or femoral access bleeding, retroperitoneal hemorrhage, other bleeding sites, and the fact is reassurance of immediate anticoagulation reversal upon complication termination. So we can now restart the patient on the antithrombotic therapy after you have done the mechanical intervention. So again, triple therapy with DAPT in AFib and PCI. There's 3 different things: stent thrombosis, stroke, and also major bleeding. And of course, you can't prevent all of them at the same time. You have to make a choice, but at least now you have the airbag that supports you if the patient has a dramatic event, as you saw like that in the cath lab. This patient could obviously have died from 2 complications: tamponade and hemorrhage, or also stent thrombosis and cardiogenic shock. So just one real quick case. This is a patient who fell. She's a 70-year-old lady with a history of chronic AFib on rivaroxaban 20. She has irregular rhythm at the time, no focal neurological signs. The ECG showed AFib. And just to come to the chase, obviously she has an acute subdural hematoma. You see the white stripe over here after the fall, and there's a shift, midline shift. So what do you do here? How do you reverse the anticoagulation? Of course, timing is important. Last dose of rivaroxaban was 6 p.m. in the evening prior to having the CT scan of the head. CT scan of 10, 17 hours since last rivaroxaban dose. You know the half-life of rivaroxaban is 8 hours, and you have a 30% renal, 60% liver clearance. So 1/4 remaining at 25%. So how do you reverse this? Is it okay to wait here? No, of course not. It's an intracranial bleed with a subdural hematoma. So in the past, we would use this. This is the 4-factor prothrombin complex, okay? And this would reduce your PT by 2.5 to 3.5 seconds. A 3-factor would reduce it only by 1 second. But of course, if we had Andexxa at the time, we should have used it. And if you think about it, everybody has told us, can you remember? More than 8 hours, yes? And standard dose, 20. So what are you gonna do? Low dose or high dose? Come on, guys. They said it 10 times. Low dose. More than 17 hours, standard dose, low dose, okay? All right, so this is from the study. You saw exactly what happens. I won't repeat that. You have a sustained drop, and then you have to give an infusion to prevent the correction. I'm going to skip all of this. This was very well covered. And then just one other case. This is a very dramatic case. As you see, this is a patient who also fell and had a severe intracranial bleed. This was after the Andexxa. This is a few weeks later, and this is at the time of discharge. It's almost all cleared up. So this patient also, by the way, had a DVT at the time. So what do we end up doing? We ended up giving the patient an IVC filter. Resumption of anticoagulation at this point is also quite dangerous. But you saw a very rapid reversal with the Andexxa alpha. This is another case who had an intracerebellar bleed, actually presented very strange, just was a little bit dizzy and a little disoriented. And then after the Andexxa alpha, I think you can appreciate, I'm not a neurologist, but I think this triangle is a little bit bigger than this little oval. So I think clearly it's reduced in size. So what do we do about the stroke risk? So now you've solved the acute problem. You're good to go. The patient has survived the acute event. Thankfully, we have to look at the long-term stroke risk. I'm just going to show you this. I found this on the internet. This is the Andexxa phase 4 study, which was just recently released. This is a press release from the company. And the Data Safety and Monitoring Board decided to stop because they had enough events to show benefit for this agent. So this is actually a very powerful piece of information. All the previous studies were open label. So the resumption of anticoagulation was studied in these long-term studies after warfarin. Now, with warfarin, there's about 36% of these patients were subdural hematoma, and they resumed the warfarin 10 to 20 weeks after the initial subdural hematoma. The rate of ischemic stroke after restarting oral anticoagulant warfarin was 13%, and ischemic stroke on aspirin, 25%, ischemic stroke with nothing, 27%. So after intracranial hemorrhage, starting warfarin was reasonable by almost a 50% reduction of strokes. However, remember that most of this was due to traumatic intracranial hemorrhage. It does make a difference the type of intracranial hemorrhage. If it's spontaneous, it's much more likely to have another spontaneous bleed. So you have to make a choice, and this is, again, a multidisciplinary approach. And in fact, back into the guidelines again, in patients with high ischemic risk, reinitiation with a preference of DOACs over warfarin in NOAC-eligible patients, especially if it's traumatic. And again, DOACs are typically safer to start. And typically the answer is in a patient with AFib and traumatic subdural hematoma with minimal symptoms, restarting 7 to 14 days with a risk-benefit analysis and a detailed discussion of the imaging with the neurologist and the neurosurgeon as well. So nobody does this on their own. Outcomes after intracranial hemorrhage are universally miserable, but I'm going to show you this again. This is a more updated meta-analysis. Antiplatelet therapy does nothing. Don't give them aspirin. It does not benefit the patients whatsoever. So this is actually what the ESC has come up with here. It's fairly complicated. There's one other thing that you can do once the patient has had an intracranial hemorrhage. It's called left atrial appendage occlusion. If you come to the conclusion with the neurologist that the patient can no longer receive oral anticoagulant, this is a well-approved strategy with an interventional procedure. We put a plug into the left atrial appendage interventionally, and this can prevent stroke significantly and prevent you from needing to have anticoagulation. So don't forget to include your electrophysiologist friends in this discussion, because we do have a solution once everything else fails. And with that, I'll stop, and thank you very much for your attention.
So thank you very much, Dr. Hani, for the amazing presentation, because usually the culprit is always anticoagulation because of arrhythmia. So this is the cause, but there is a solution, and it's been a very informative session. I'm still waiting to get your questions that were submitted on the QR code. Until we figure out that technical, I'm going to invite my colleagues, speakers on the stage, so we can have our Q&A session. And that's the only thing, holding us before dinner. So, yes, if we can have them, and I'll just invite my colleagues, experts on stage. We'll have enough chairs. Awesome. So we have an amazing set of questions. That means really engaged audience who've been with us for the past 2 hours. So I'm gonna start with the first questions, and it's for any of the expert panel. I'm not sure if we have anyone online with us, or yes. So the first question is, yes, they are with us here. So if we can also direct the questions to them too. So the first question is about, what about using Andexxa alpha as a reversal agent before any surgical procedure? Who can help us? Is that an indication that was discussed?
So if the surgery, as we pointed out, there are specific surgeries that can't wait. So for example, a heart transplant. So heart transplant, you have a patient on perfusion, you have the donor, you can't wait. So this is one of the reasons why a patient, for example, like that can benefit from the use of Andexxa alpha. Most surgeries generally can wait. If you wait 1 half-life, it's 50%, 2 half-lives or not. If a patient has an acute abdomen or perforated viscus, okay? Or for example, somebody with an abdominal aortic aneurysm. So these are patients where the surgery itself is life-threatening without any delay and must go to the operating room.
And this is what we are saying with neurology, subdural and epidural. It's life-saving, especially if the patients start to drop level of conscious and they start to comatose. You need to reverse it. And usually the neurosurgeon, they are very concerned to touch these patients because just opening, it will bleed like crazy and it will not stop. So this is going to change the game.
I think it's not indicated for elective surgery. If the patient can wait for more than 12 hours, should be avoided. I think the Andexxa, they included patients who have major bleed intracranial hemorrhage. I think maybe there is another, trial for reversal or urgent, reversal of DUAC before urgent surgical intervention.
Awesome. Thank you very much for the panel for addressing this question. So I have another question is, how can we reduce or improve the time to reversal by empowering emergency physicians to make decisions fast and on time? So I'm going to have Professor.
I think emergency physicians are pretty fast nowadays. They don't have much time to keep hold of patients. The important thing comes down to, again, history. Because most of the time we don't have the history, whether the patient is on a oral anticoagulant or not, and when was the last dose that was taken. Because if the patient comes on their own by an ambulance without any family member and they are unable to talk, it becomes very difficult to tease out that information. And you have to go into the records, but it still doesn't tell you when was the last dose taken and whether there has been any change in the medication subsequently. So the key boils down to the history. If we know the timing and we know the dose, then if you put up a protocol which is actually, it's well-read, well-rehearsed, and well-practiced, then emergency physicians will be the persons who will make the decision at the right time for the right reasons, for the right patients. And I think we can empower them to do so, and that's the aim we should be looking forward for the future.
If I can also just add a small comment.
Add one comment on this. So maybe what we learn from disaster medicine is mitigations. So you have to know very well your target populations. If you have a lot of patients in DUAC, then maybe your resident, your triage physician, nurses, your resident should be aware of DUAC bleeding when they come to the emergency department. By this, we accelerate the care of those patients. Being reactive, you need maybe a consultant to do the case. But to catch all patients who come to the emergency department with DUAC-related bleeding, I think we have to increase the awareness of the end users, the emergency physicians, the nurses, the triage physicians, about the DUAC-related bleedings.
Awesome. I just also want to add one thing. I think, our EMRs are so smart and have really helped us really advance our care. So as simple as, you remember when they were rolling out early during residency, the sepsis protocol and how to recognize sepsis. So as soon as I enter into the chart, I will get an alert. This patient meets the actual SIRS criteria, make sure that this patient doesn't have sepsis. So something like this, that as long as we know that this patient is on an anticoagulant, we will get alert. Is this chief complaint related or could be affected by that? It's simple because sometimes, the mental, you're so busy, the shift is so busy, these small things may fall in the crack, but they are yet very important. So empowering us to use EMR to help alert who are at risk will be important, I think.
I just wanted to follow up on this point. So now in Abu Dhabi, we have something called Malafi. So you can see every single medication prescribed. The patients are going to tell you, I don't know the pink pill, the green pill. You can immediately see that the patient's on a DOAC. And I think this is the most important point. If you don't recognize that this is DOAC, you won't enter this pathway. And a lot of patients, as you said, they come unconscious and the families don't know, or they're panicking and nervous. The second thing is, I think, empowerment. These medications do not cause prothrombosis, right? Unlike the old prothrombotic therapies. So there's no downside risk to giving this medicine, apart basically from the cost. So it's basically, if it's a life-threatening bleeding, severe bleeding, car accident, something like that, then you go fast. That's the key point.
I think this is very important. It is similar to other concept, pulmonary embolism response team, PERT. It's another project in our hospital where emergency physician is empowered to be part of the team. I think you are very, proactive, highly enthusiastic. Other, ER physician, they don't want to get involved in a critical decision. I'm not general talking, like for thrombolysis for massive pulmonary embolism, here for reversal of anticoagulant. They say we don't want to take extra responsibility. This should be done by other, physician. Like I think I really like. What you have done.
The only reason sometimes we refuse is because you want other specialty to just practice their. So usually,
just
I have a very quick comment on this. Cardiologists love to give digoxin. Some of them. I hate digoxin for my patients. Now, we know that digoxin has major complications when it comes to overdose because they have very narrow therapeutic window. So I decided, if my cardiologist decide to give digoxin in their patient, Digibind, which is the antidote for digoxin, should be available in the emergency department. Otherwise, I want to allow digoxin to be given in the BT committee. The same thing apply if you decide to put your patient in DUAC. Make sure the referral agents are available, and that's what they are doing now in National Guard Hospital. They have the Andexxa in the emergency department pharmacy. So there is around 10 vials ready to be used in the emergency department for any patient come to the DUAC. So I think and this is not only for DUAC, for any type of medication. If you start new medications, you have to make sure that there's available referral agent should be available in the emergency department, because there's the area where they use the referral agent for patients with bleeding.
Very simple. In the neurology, when you use the thrombolysis or the mechanical thrombectomy nowadays, we will write it's life-saving procedure. Andexxa is a life-saving procedure? Is it a life-saving medication? Maybe for gastro, you can wait for a couple of hours. Maybe for others, but for the neurology, when they have this massive bleed, usually TPA in Dubai, in few hospitals, is given by emergency doctor. Is given always in my hospital by resident. It's not the senior people is coming. So a medication like that, which can make a difference in the quality of life, mortality drop by 50%, NIH stroke scale drop by 6. This means a lot for us. So for that, it should be used as life-saving in the neurology field, because it's a life-saving. You're changing the endpoint.
Sohail, I want to ask you, you are the neurology chief in Rashid, you're in Med Clinic. So the patient comes the door, we have seen everybody, Sean, Mohammed and everyone, that the door to needle is the most important. So what is the protocol you have when the patient comes with a code stroke? How do they go? How fast do they go through the scanning? And how fast they go to receive? How is it that you're managing to do it within 60 minutes?
Yeah, unfortunately, we are not doing it within 60 minutes. Our mean average time is 32 minutes. Yeah.
Great.
Okay, so 60 minutes is too much for this. So I believe thank you, 32 minutes. Yeah. So, for ischemic stroke, yeah, sure. That's the door to needle. But and door to groin is almost always less than 90 minutes. If during that daytime, sometimes we skip the thrombolysis going directly to the angio suite. So just to say it's 60 minutes for AstraZeneca, I think that is ICH code for ICH. That's too long for the intracerebral bleed. So we are getting pre-notification by ambulance everywhere in Dubai. Stroke code is coming, so everyone is ready. Within 6 minutes, CT is reported from the arrival. So we will know that there is bleed or no bleed. So if you got the bleed, immediately the medication is in that triage area. Your pharmacy is there. Just prepare it and push one there if the patient is known on NUAC, and you solve the issue. So 60 minutes will drop to 20 minutes, very easy. But the point is when to start it, when to use it. I'm a little bit concerned about using this medication overuse. For example, with the thalamic bleed that we saw, just I discharged a lady with a small thalamic bleed. She went home after not 10 days, after 5 days, walking, talking normal without using the antireverse because she was severely hypertensive. And we need to understand in neurology what the source of the bleed or the etiology. Is it the NUAC? Oh, no, it's not the NUAC. It's the poor hypertensive lady. Oh, they have a vascular malformation. She has a small cavernoma which bled. So it's not just blaming the anticoagulation. She's on 2.5. Regular, taking that medication for the last 5 years. Why she bled now? Oh, she bled because her blood pressure always above 180. So that's what gave her the bleed, is not the anticoagulation. Got it? So.
Awesome. So I have a question for our colleagues from hematology. Has the rotational thromboelastometry or the TEG have any role in monitoring such bleeding or the bleeding management?
This is used mostly in the theater and the surgical, and most people who are using it, the anesthesiologists, they are the one who are experienced to using this. Actually, hasn't been used routinely in the emergency department, no.
Yeah, even not used in the clinical, only as in the OR by anesthesia, not used in the ward, not in the ICU, maybe my colleague, so.
Professor Stefan, are you still with us? Can you hear us? No? Okay.
Dr. Asha, can I comment here?
Yes, Dr. Hazza, تفضل.
Thank you. So to answer your last question, I agree, Doctor, with all colleagues that the thromboelastogram and ROTEM are used mainly in cardiac surgical ICUs, or intraoperatively or post-operatively, and in liver transplant setting. They're not used routinely in clinical setting. Regarding the I think we should not look at Andexxa as a triac that absolutely has no potential side effects. This is very important because this can lash back against our own practice in the future. Professor Stephen Meyer is with us. He showed us the risk of thrombosis in patients in the Andexxa eye. It was near double that of the, correct me, Hamdi, if you're with us. And there are also several other small-scale studies that shows some increased risk of reaching up to 16%. So we have to be very careful and meticulous and judge carefully on the risk and benefit of the drug. The drug works for a short time, only 2 hours, and then its effect is gone. So, and then the big question comes, and this is what we face in patients who come with major bleed, and then you take them to OR, and then the anti-10A activity is back. Theoretically, would you use some maintenance low dose, at least during the interop period? I think we really have to balance the risk and benefit. And there are some centers that only use it for intracranial bleeding and not for other major bleeds. That's my suggestion. For pre-op use, there's, Hamdi, you can add to what I'm saying. I think I'm aware of only a single center observation retrospective study where they compared with some positive signal that this drug may help in the pre-op setting. And we have used it actually in 2 patients in our hospital, exactly like what was stated in a cardiac transplant candidate. unfortunately, the heart was delayed, so ultimately he got the Andexxa without getting the transplant. So that's my short comments. Thank you.
Thank you very much, Dr. Hazza, for your valuable input. So the last question I have here, this is a patient with end-stage renal disease who developed massive intra-abdominal bleeding on apixaban 2.5 milligram. The last dose was 12 hours ago. Currently in hemorrhagic shock, hemoglobin is 6. What is your approach?
So this is going to be a little bit different, right? Because the 50% bioavailability of the apixaban is renal. And you know, it is now labeled, there's a labeled indication to use apixaban in patients on dialysis. So I think the question is going to be, are you going to give the patient full dose or half dose, right? Because the timing and the dosing is underdosing. This, I think, is not going to be easily resolved by any of the guidance, and it's not really specifically written here in the label. They didn't really include patients like that, but it also makes sense that this is going to have a persistent bioavailability. This is going to be a patient who's going to need the longer infusion. I think logically speaking, if you have that profile in this particular patient, a longer infusion, basically the higher dose infusion is going to make sense. But I'd like to hear what the other colleagues are suggesting.
Yes, per the protocol, it should be given low dose because 2.5, should be given low dose regarding regardless of the time, less than 8 hours or more than 8 hours. I think if it is, for the dabigatran, there is another modality for hemodialysis. For hemodialysis to clear the drug. But this hemodialysis doesn't work. I think, bleeding in patient end-stage renal disease is more catastrophic, difficult to manage. Although it's approved for use in patients with end-stage renal disease 2.5, we have seen some bleeding, like GI bleeding in these patients. Just to add another important point, most of these end-stage renal disease patients, they are medicated on polypharmacy and on aspirin. I think this not only is apixaban 2.5 is, it's multiple antithrombotic medication, is antiplatelet in addition to apixaban 2.5. That will be, I think, the culprit and cause for a GI bleed. So. Or for other bleeding.
Awesome. Any other comments from the?
I just have maybe a final comment, especially for our colleague will face, the question when to restart the anticoagulant. I think nowadays we should have patient part of the decision. So, and that's what we do in the ICU. We get patient and patient family in board with us from the beginning, from day one in the ICU. We call it A, B, C, D, E, F. So F is family and patient. So I think, family and patient should be part of the decisions. They have to know the risk and the benefit for restarting the anticoagulants, and they have to share the decisions with the clinicians. Thank you.
One of the problems we find with the use in renal failure, end-stage renal disease, is unpredictability. And we have had so many patients, they have very prolonged PT-PTT due to the DOACs, although DOACs, and there's no correlation between PT and PTT with the level of the anticoagulation. But we see this, and the renal function, especially in this patient who are elderly or have been given, the renal function tends to change. It worsens for acute illness, and therefore, they get accumulation, and we see lots of problems with using renal failure.
So if I could just make a comment, I think, over the last decade or so, the DOACs have become bread and butter, right? And they have replaced warfarin almost completely, except patients with specific valvular atrial fibrillation, which is the minority of patients now. So I think it's upon us, every single physician has to know these like the back of their hand, exactly the same as we know hypertension or even dyslipidemia. And we have from every specialty, as you've seen, right, really have to be very familiar with the encounters that we're talking about. So we have reversal agents. They act like an airbag. There's no car now that is built without an airbag, right? We also have to know how the airbag works, because unlike a car, we are the ones who are going to press the button and we're going to make it happen. So I think there's been some very nice insights about having protocol-driven medicine. I think everybody has to be empowered how to know this. This might happen in the hospital. We've had patients who have bleed in the hospital, right? So the intern at 2 in the morning needs to be able to order the stuff and get it. There shouldn't be arguments with the pharmacy. You don't have the consultant's approval and all this other stuff. So everybody has to know this. This is bread and butter information. It's life-saving. These tools are just tools, but you know, if you have to deal with them, you don't want to be looking them up on UpToDate at 3 in the morning and arguing with somebody, where is this medicine? I don't know how to mix it. I can't give it on the floor. My nurse is not licensed. There's so many obstacles that you know for real do happen, and I think that's the key thing. Any drug or any randomized clinical study is fantastic, but unless you put it into practice and people know exactly how to do it, when it's an uncommon occurrence, I think is the most important thing.
Absolutely, and that's where protocolizing it, putting it in the clinical pathway really makes sense, because that intern at 2 a.m., 3 a.m. will probably call the consultant, knows actually what is required because it's laid out there. The protocol Dr. Hazza showed us, it's clearly written in the EMR. So even if your brain cells at 3 a.m. doesn't want to work, it's clearly written there, dictated. And I think education, training, putting everyone in comfort in making that decision and making the patient and their family in the center of that decision making, I think is essential. So with that, if anyone else has any other comments?
Because is in fact the GI, as Dr. Jay said, the GI complication is the most common complications after anticoagulant. In fact, there's always discussion on dilemma when we have to go to the endoscopy to look after the bleeding source. That is always, as you said, that is most of them, they are elderly people, and for colonoscopy we need a clean bowel. And clean bowel we are not achieving before 12 hours. That is always the problem. And we cannot force actually hydration and flushing the bowel before that, because as I said, most of them have comorbidities. Also that is you have to wait 12 hours till...
One more.
Yes, yes. So that's the closing. No, I'm joking. So with this, I really would like to thank all our esteemed speakers, moderators, Dr. Hazza, for really being with us virtually, not with us in person, and more specifically to all of you to be here to really exchange knowledge and, you know, hopefully share more success stories of having, you know, things that we can be empowered to do to improve our patient care. So jazakum Allah al khair. Have a good evening and please enjoy.
Thank you. Thank you all. Assalamu alaikum.